Good morning, friends. Look at this nice room. Thank you all for being here. For those of you who could join us last night, thank you. Good morning, and welcome to our 14th Annual National Forum on the Future of Healthcare. That is an incredible number. So really excited for our program today. For those of you I haven't met, I'm Lisa Lacasse. I am proud to be the president of the American Cancer Society Cancer Action Network, which is a huge mouthful, so we just call ourselves ACS CAN. And I just want to say thank you for joining us today. We have a very full room and nearly 200 people that are joining us online. So for those of you online, welcome as well. We definitely want to hear from all of you. We're going to have opportunities for people in the room to ask questions. And for those of you online, I'm going to read this so I don't get it wrong. Apparently on the top right of your screen, there's going to be something titled Ask the Presenter a Question. So we really want you to be engaged in the conversation today. If you've got a question, put it into that little gadget, and we will make sure that those questions get to our panelists. We also invite all of you who are good on social media. We really want to try to break through today. There's a lot going on, but please use the hashtag cancer screening, tag at ACSCAN. And I know with everyone in this room and all of us amplifying, we can actually break through. This is such an important issue. This cancer lens does not get as much attention as it needs to, and we want to change that with this conversation today. We know screening and early detection is absolutely imperative in the fight against cancer. So this is our opportunity collectively to really elevate this issue. I want to start with just a little bit of background. So ACS CAN, we are the nonpartisan advocacy affiliate of the American Cancer Society. We are the largest and, dare I say, probably most powerful cancer advocacy organization out there. And we are that, and I can say that with pride, mostly because we run through our volunteers. We empower this phenomenal grassroots mobilization in all 50 states, Puerto Rico, and Guam. And it is our secret sauce. It allows us to elevate the patient voice and constituent voice that elected officials really care about, and there's no one else that can do it the way we do it. Our mission is girded and underlies by evidence, right? We are all about evidence-based public policies to reduce the cancer burden for everyone. So it is a very politicized environment right now. We're used to it. It's what we've been doing for decades. But the reality is that ACS CAN takes positions because the evidence has shown us that the public policy intervention that we are advocating for is better for cancer patients and their families. And so we proudly are able to walk into every elected official door and talk through why a policy intervention is so important in the fight against cancer. So our forum today, we have an incredible agenda. We're focused on cancer prevention and early detection, as you all know. It's an area, as I've noted, it demands more attention and focus. There's a lot of complexity, but also an incredible amount of excitement. I've been in this role since 2019, but with the organization for more years than I'm going to tell, because it means that I'm getting really old. But it is the one area I would say that has just exploded from an innovation standpoint, and it's just really exciting because we know that this part of the cancer continuum, the prevention, early detection, can really, really change the future of these diseases. We know that we are getting closer and closer to an opportunity to understand in depth our own personalized risk and a screening and prevention sort of overlay to our individual personalities and our own biologies and our family history. But that, one of the things that we know, and we're going to hear a lot from today, is that all the science and innovation is ahead of where we are from a systematic standpoint, from an insurance coverage standpoint, from a regulatory standpoint, and it's our jobs collectively to change that. I like to say, and we're saying it a lot right now, we are not about business as usual. We have to change the status quo. And the only way to do that is to work together, but also for us to work nationwide to make sure there's equitable change to that status quo. Cancer screening and early detection, there's more than enough evidence to show that it saves lives. We know treatment is significantly more effective and more affordable. Certainly in the case of cervical and colorectal cancers and others to come, screening can prevent the actual development of cancer by identifying and removing precancerous lesions. So that becomes prevention, right? According to a study recently published by the American Cancer Society, cancer prevention and screening is estimated to have averted, this is an incredible number, 4.75 million deaths from breast, cervical, prostate, colorectal, lung, and prostate cancer twice, alone between 1970 and 2020. So really 4.75 million, that is an incredible number. And we certainly celebrate the wins, but there's so much more work to be done. We know that screening tests exist only for 5 cancer sites, not nearly enough for a disease that's over 200 different diseases, and certainly sub-diseases within. And the uptake of screening is just too low. What's more, we know that there are serious disparities between communities leading to unequal and unnecessary burdens of cancer. So I want to urge all of us again to stay focused on what we need to do as we're learning and hearing today to shifting the status quo. We know more access to existing screening has to become a reality, but we have to reduce and eliminate barriers to the innovations that are going to save more lives. We want to focus on oncology care as, in some ways, as a primary care component, making sure that everyone greatly understands how they can reduce their risk of cancer. More than 2 million lives this year, 2 million people will hear you have cancer. They'll hear those words within these coming 12 months. So we're depending on all of us in this room to change some of those statistics. So our forum today is going to address these issues head on. We have an incredible keynote, which know everyone is going to really, really learn from. Our first panel of experts is going to talk about the current state of screening and early detection. Our second panel will focus on what's new and the many amazing innovative approaches, many that are not on the horizon, but with some really important policy interventions are going to be accessed by cancer patients now. We'll have an eye-opening luncheon discussion about the prevalence of cancer in younger adults. This is an area that everyone's really interested in learning more about, what we can do to support these patients, and then followed by a final panel of the day on how we can remove cost barriers, in particular to screening and early detection. In front of you, or most of you picked up a blue folder on your way in. Each of these forums every year, as I mentioned, we've done this 14 times, we often have brand new data to release, and today is no exception. We have new data to share from a nationwide survey that ACS can deploy to understand the patient experience and perspectives of screening and early detection. And this is data you don't always see, and so it's really exciting for us. It's a really great polling memo. I hope you have time to look through it, but a few highlights. So the survey was just conducted in April, so really new, with 1,000 screening age adults nationwide. 1/3 reported being more than a year behind on a recommended routine screening, 1/3. When asked the main reason for being behind, the single most frequently mentioned response was that they were afraid of costs, and that roadblock was followed by insurance pre-approvals and just the logistics overall of getting screened. We all are in, or many of us are maybe in that demographic and know exactly what people are talking about. In the cases where individuals required additional screening following an abnormal result of their first screen, 1 in 5 said they were billed for the additional screening, and 1/3 said they had to get pre-approval from their insurance. So we know screening isn't necessarily a point in time. There is a process to ensuring that you get to that no diagnosis or diagnosis. So the only thing more concerning than worries about how much it would cost were concerns about a potential upsetting diagnosis. But we know delays and missed screenings lead to worse outcomes for patients, and you can see a lot more in the polling memo, as I mentioned in front of you. So we have a lot of work to do to address costs across the full continuum of screening. We have to ensure that that screening process provides patients with the information and action steps they need to get timely and appropriate diagnostic and treatment care as required. And again, to developing effective new tests and interventions that are accessible and affordable to everyone, and that's a lot of public policy work. We have so many champions in Congress and in state houses across the country who are sponsoring bills to eliminate patient cost as a barrier to screening, fund evidence-based screening programs, and develop new payment pathways for innovative new testing to make screening more accessible. There's a lot of work happening in this space. We just need more. But we certainly are facing challenges in the courts in particular right now, and coverage just generally preventive services. As we're facing threats of cuts to federal programs that provide expertise and funding to states, territories, and tribes to increase screening uptake, particularly in communities that are historically underrepresented, we need all of our voices as allies to make sure that this does not happen. As advocates for cancer patients and survivors and families and all of us who are at risk of the disease, we're committed to advancing solutions that promote prevention and early detection as the first line of defense to end cancer as we know it for everyone. So we need commitment from everyone in the room. We know together cancers can be prevented. They can be detected at an earlier stage, increasing the number of survivors living long and healthy lives. So a tremendous thank you in advance to our incredible volunteer storytellers. You're going to hear some really amazing stories today. I often talk about being a patient advocate. If I get invited to speak, I'm often at the end of the program. And I always want people to flip that around and get the patient perspective at the front. And so we will be doing that with each of our panels today. And so just a huge thank you for all of you who are in the room, for all of you who are watching online. And I want to quickly end by saying a huge thank you to our sponsors. We could not have this room, we could not do this work without the support of our sponsors. And I'm proud to say, I will list them out, but you see them here. They are not only our supporters, but they are our strategic partners. And we work so closely together because you have information we don't have, we have information that you don't have, and when we put that together, there's a lot of magic and really important ways to influence. So our gold sponsors, Bristol Myers Squibb, Genentech, Grail, Guardant Health, Merck, Novartis, Pharma, and Sanofi. Silver, Astellas, B1, Exact Sciences, Genmab, Ipsen, Johnson & Johnson, Lilly, Pfizer, and Takeda. And our bronze sponsors, AstraZeneca, Daiichi Sankyo, Genoscopy, Quest Diagnostics, Roche, S32, and Siemens Healthineers. So thank you. Can I get a huge round of applause for our sponsors? And now it is my great honor to introduce someone who has been an incredible partner to me, to our work, the chair of the American Cancer Society Cancer Action Network Board. See, this is why we say ACS CAN. That name is just way too long. Dr. Kim Jeffries Leonard, who will introduce our keynote.
Good morning. I am Kimberly Jeffries Leonard, and I am very proud to be the chair of ACS CAN's Board of Directors. But before I introduce our keynote speaker, I would like to echo what our president, Lisa Lacasse, said in expressing commitment to assuring affordable, equitable access to cancer screening and early detection. ACS CAN's important ongoing commitment to addressing the inequities faced by many across the continuum of cancer care, from prevention and early detection to treatment and survivorship, relies on the identification and implementation of real solutions. Screening and early detection is life-saving, but not everyone is benefiting from these important advancements. In 2023, 69% of white women were up to date on their breast cancer screening, compared to 59% of American Indian and Alaska Natives and 64% of Hispanic women. And while white women and Black women have similar breast cancer screening rates, Black women have a 40% higher mortality from breast cancer. Can we imagine how much higher that number would be if it weren't for screening? In her remarks, Lisa mentioned some of the barriers people reported when accessing cancer screening. Lack of access, uptake of cancer screening impact a person's survival from cancer, and it cannot be ignored. For example, people who are LGBTQ+ face significant barriers accessing healthcare and fear of provider discrimination, which has led to lower screening rates and greater risk of cancer than heterosexual and cisgender people. It is imperative that individuals have access to all recommended screenings and the full complement of tests at no cost to effectively prevent and detect cancer early and hence save lives. Conversations and solution-building moments like this one are critically important. But most importantly, we are committed to taking the next steps to ensure that actual change is made. So on behalf of ACS CAN's board leadership, we affirm our commitment to act, to ensure we advocate for policy solutions to ensure that everyone, including communities of color, have access to evidence-based preventive services, including cancer screening and early detection. So I thank you all for being here to support that commitment. Now, I am pleased to introduce our keynote speaker, Stan Lapidus. Stan Lapidus. Stan is an inventor and an entrepreneur. He was the founding CEO of 3 medical diagnostic companies, including Cytek Core, which revolutionized the early detection of cervical cancer by developing the modern Pap test, and ThinPrep, and Exact Sciences, which pioneered non-invasive early detection of colorectal cancer through its Cologuard test. Stan holds 38 patents. Please join me in welcoming to the stage Stan Lapidus, our keynote speaker.
Good morning, ladies and gentlemen. I'm really honored and I'm quite touched by being invited to speak here and perhaps lay out some of the key parts of today's agenda. The reason we're here today, first is because of one man, George Papanicolaou, and then one organization that supported him through what was initially a long and lonely journey. Papanicolaou was a Greek immigrant. He came to the US in the early 20th century. He was a faculty member, a poorly supported faculty member at New York Hospital Cornell Medical School. So some of his research was funded. He took research dollars wherever he could by a eugenics group called the Race Betterment Institute. That's not the human race, that's the white Northern Protestant European race, the founders of which were the Kellogg brothers of cereal fame, one of whom, Harvey Kellogg, was a physician, and his goal was to provide selective breeding advantages to white Northern Europeans, of which Papanicolaou was not, nor am I. His research was on determining the optimal time for a white Northern European man to impregnate a white Northern European woman by studying vaginal effluent, the stuff that comes out when you rinse the vagina with the saline bulb. He started on guinea pigs. His most important human subject was his wife, Abramson, herself a towering figure in the history of cancer prevention. He discovered, accidentally, that he could detect cervical cancer and precancer through these vaginal irrigations that he performed initially for a different reason. He presented his results for the first time in 1928 at the 3rd Race Betterment Institute conference. His work was profoundly ignored. He continued to work alone until the 1940s, when he collaborated with a gynecologist named Herbert Trout, and that really began the modern era, the only era, of cancer prevention and early detection. By 1947, the one group that made a difference here, the American Cancer Society, did a few very important things. First, in 1947, it began a clinical trial that I think ran for 4 years or so, simply asking the question, how prevalent is cervical cancer and precancer in unscreened women, because basically all women were unscreened. So 100,000 women at no known predisposition for cervical cancer was screened, and the rates were 0.7% had cancer that was not yet symptomatic, and 7% had cervical precancer. Those numbers match exactly the numbers today in the unscreened population for colorectal cancer, which is to say, were it not for the pap smear, it would be, and it was then and would be now, the #1 cancer killer of non-smoking women. It was an astonishing result, and it galvanized ACS into one of the most successful public health promotion and advertising campaigns in history. I was a child in the 1950s and remember seeing ads for the pap smear. I didn't know what it was, but the ads were everywhere, and they changed cervical cancer from demonstrably, based on epidemiologic data that ACS collected, from the #1 cancer killer in women to a fairly uncommon cancer. There are 14,000 cases a year and almost none in women who are regularly screened. It was demonstrated two things: that early detection of cancer saved lives, but more importantly, detection of precancer prevents cancer. So by the time Papa Nicolau died in 1962, as quite a revered figure, as a man who worked alone, and then again with ACS's support, he changed the history of medicine. He changed the history of medicine not just for cervical cancer, but for many cancers, because he demonstrated the thing that we hear today to celebrate and to further, that early detection saves lives. The first mammogram was done in 1918, but mammography became, so the technology was available for decades before it became common. Mammography really caught fire based on the success of Papa Nicolau's program to reduce incidence and mortality from cervical cancer. So the second cancer to somewhat yield to early detection is breast cancer. The third is colorectal cancer. The fourth is lung cancer through screening with spiral CT. The fifth is PSA, and which leads me to talk a little bit about evidence-based medicine. What do we know? We know for sure that cervical, breast, colon, and lung cancers, screening for them reduces mortality. For prostate cancer, initially the evidence was quite mixed. I believe it was because of flaws in study design. So let's say there are 5 cancers for which early detection saves lives. Again, 2 are radiology-based, 3 are lab tests. So it's the combination of imaging and laboratory testing that has made a tremendous difference. These tests, mammography, colonoscopy, Cologuard, Garden Shield, which is the newest test to be approved, which is a blood test for CRC, PSA testing, and low-dose CT for early detection of lung cancer together address potentially 40% of all mortality from cancer, leaving 60% unaddressed. Most of my remarks are going to concern the 60% today. But it's important to note that, and emphasize what we already talked about, which is that access remains a problem. Not everyone who should and could get screened does. I live in Colorado, where people live hundreds of miles from access to follow-up, even if their primary care physicians can provide a pap test or an HPV test. Following up with a colposcopy, following up with stereotactic needle biopsy for breast cancer is a challenge. There are racial and ethnic disparities, income disparities. We need to address those. Addressing those involves making tests more accessible, making the follow-up more accessible, and making the intervention less dramatic. If any of you have had a colonoscopy, as I did for my market research for Exact, you'll know that it's a daunting procedure. I wanted to be sure I knew what I was talking about when I proposed a stool-based test. And the challenge of evidence development, which leads to reimbursement, leads us to a curious conundrum today. There has never been a time in the history of diagnostics, regardless of technology, in which there has been more ferment, more good ideas, more innovation than now in early cancer detection. There has never been a time in which it's been harder to raise money for cancer diagnostics than now. It is extraordinarily difficult. Part of it comes from broad secular trends, an economy that's in turmoil, a stock market for IPOs that has its ups and downs. But the main obstacle to funding diagnostics is the uncertain nature of reimbursement. For the 5 cancers you talked about, reimbursement is in place. So if you develop a new prostate cancer test, if you develop a new colorectal cancer test, breast cancer test, you will be reimbursed. It'll be a struggle and there'll be many sleepless nights, but you will be reimbursed. Without legislative changes, no cancer that isn't one of those 5 will be reimbursed. And investors say in this environment in Washington, it's uncertain that there'll ever be reimbursement. So this is a big deal. I'm going to make my conclusion is going to be about a bold initiative that I propose, how to fundamentally change this. But it's important for everyone here to realize that we're kind of stuck. We can develop technologies, but if we can't point to a pathway for reimbursement, raising investment dollars is extraordinarily difficult. There are 5 challenges, in my view, about doing a much better job at preventing and detecting cancers early. And they are biology, technology, evidence creation, and payment. Let me start with biology. In speaking about the most exciting change to come along in decades is the approval of Guardant's Shield test. It's a blood test for CRC. FDA approved with very strong and very clear data. For stages 2, 3, and 4 cancer, it's a clear win, 100% sensitivity. For stage 1, I think it's 60% sensitivity, and for premalignant lesions, more work needs to be done, and it will be done. I'm confident that I believe that blood will prove to be an important analyte, not just for colorectal cancer, but for many cancers. However, the biology question is this: are early stage cancers or precancers in communication with the bloodstream? Today's data from GRAIL and from Guardant says we don't know. We don't know the biology of the communication between early cancer and the blood. That's a biology challenge. There are many challenges in cancer research. I think the number one challenge for early detection is addressing that question well. Again, the advantage of blood tests are you can test for many cancers at once, which will lower the cost of clinical trials, increase patient access, and increase convenience. And the challenge is clear evidence that early detection is possible. You'll be hearing today from speakers from Guardant, from Exact, from a company of which I'm chairman, Mercy, about why one should be optimistic about the future of going earlier in blood-based detection. And the technology challenge is, what's the right marker? Is it DNA, RNA, extracellular vesicles, exosomes, proteins? These are all competing technologies and are part of the ferment of why this is an exciting time. Who the winners will be is hard to predict. I suspect it'll be a combination. No one analyte will win. Now I want to talk about the great problem, which, as I mentioned, is reimbursement. So reimbursement depends on evidence. Evidence means not early detection by itself, but early detection that leads to mortality reduction. We do screening not to find cancer early, but to save lives. So mortality reduction is the right endpoint. But half the studies, the randomized controlled trials, to demonstrate mortality reduction in tests that we now know work have failed because of study design errors. And this is a 20-year process. So from conception to completion to evidence creation from mammography took actually more than 20 years to show there was a mortality reduction. the wrong populations were tested. They were tested with poor compliance. They were tested lumping postmenopausal women with premenopausal women, using the wrong comparators, before finally, after almost 30 years, the consensus emerged that indeed mammography saves lives. For lung cancer, using low-dose CT, an 8-year study which involved 2 years of planning and 1 year or so of data analysis. These things take forever. We who develop technologies can't wait. This is the chicken and the egg. We can't raise money if we tell investors we've got to wait 20 years to show evidence to be included in guidelines, yet who's going to argue against evidence creation? So we need new methods that are scientifically valid for evidence creation that doesn't take 20 years. Because that unlocks payment, and without payment, there's no investment. So chicken and egg. Another important barrier is the size of clinical trials. Clinical trials, the clinical trial we did for cervical cancer, mostly we detected cervical precancer in our ThinPrep trials, took 5,000 patients because of the prevalence of cervical premalignant cervical lesions. We only had 7 cancers in 5,000 patients, but we had hundreds of premalignant lesions. Exact studies have taken between 10 and 20,000 patients. To do an ovarian cancer study will take between 50 and 100,000 patients if we were to do it prospectively. These are unsupportable, and so one asks, well, how do you overcome that? By combining cancers. Multi-cancer early detection is a win for patients, and it's a win for technology developers. The only analyte that makes sense to look at, or the only thing to be tested, is blood. But again, the presumption is that people in this room and others working in the field will find ways to detect early stage cancer and detect precancer in blood. Still remains a challenge. But evidence creation will be simplified, clinical trials will be simplified by thinking about the benefits of multi-cancer early detection. Which leads me to the last point about reimbursement. Again, that unlocks investment, investment unlocks innovation, innovation unlocks lives saved. Cancer screening was never anticipated in the original Medicare legislation in 1965. That legislation focused on treating patients that were ill. It made a lot of sense. There's been a dramatic increase in the average life expectancy since 1965, much of that to prevention of heart disease and prevention of cancer. Yet every cancer for which screening takes place today required an act of Congress. There's never been a time more difficult than now to get an act of Congress passed, no matter what your agenda is. So we need to break through that. A couple of things of import of the moment, which I'm sure will be discussed later today, are the Braidwood case in front of the Supreme Court about the role of the United States Preventive Service Task Force. This body, just 14 people, is a jewel in the crown of the American healthcare system. We should hope for a favorable outcome and support USPTSTF's work in evidence creation. Its work goes just beyond cancer and just beyond preventive services. They have set the standard for evidence-based medicine throughout the globe. The second is a bill that's pending before Congress right now. My colleague Dawn perhaps will speak a little about it. This is legislation to create reimbursement for cancer tests that look at least 2 separate cancers, so multi-cancer early detection, multi means 2, that are FDA approved. This will reinvigorate the FDA's role in cancer screening, which I believe is super important. I am quite afraid that a lot of quackery will emerge since the FDA has been instructed by the courts to back off of lab-developed tests. There's nothing wrong with lab-developed tests per se, but the FDA standards of rigor in demonstrating clinical performance is without equal. And as far as cancer testing goes, it's very important the FDA have a voice. They will have a voice if this legislation passes. But I think the most important thing that I would urge ACS leadership to do and to focus on is a simple but important change to Medicare. Maybe the timing isn't right now, but I think 60 years of history shows that it's essential, and that Medicare law should be revised so that screening tests that are FDA approved are reimbursed. Private insurance follows Medicare. If we do that one legislative change, which will save lives and save money, the world will be a very different place. This is something no company can do. This is something no academic group can do. But ACS's demonstrated ability to move the legislative needle is, I think, where the future lies. So we know today that early detection saves lives. That began with the work of Papa Nicolau. It can save more lives through better access to the tests that we have, through the wonderful work that ACS volunteers do, and through your highly effective legislative program. So thank you very much. I think we're going to have a fascinating program this morning, and I hope that my remarks helped frame some of the things we'll be discussing today. Thank you.
Good morning. I'm Kristin Sloan, Policy Director for ACS CAN. And Stan, I'd like to thank you for those incredible remarks. Another round of applause, please. So Stan's remarks set the stage for our discussion about cancer screening and early detection. And we're going to begin with our first panel now on where screening is in the United States. Each panel will begin with one of our amazing ACS CAN volunteers sharing their story. So right now, I'm very, very happy to introduce Russell Wright to the stage. He is an incredible volunteer from the state of Georgia. Welcome, Russell.
Good morning. It's been a little over 2 years, so please forgive me because being here is stirring up a lot of emotions, a lot of feelings that I avoided. And so giving this speech and sitting here, all those emotions are starting to come forward. So please forgive me. My name is Russell Wright, and I stand before you today at 61, soon to be 62 next month, year-old prostate cancer survivor. Being a husband, a father, a martial artist, but above all else, being a grateful man. Before cancer entered my life, I was someone who believed in strength. I hold a 5th degree black belt in Taekwondo. I'm a double gold medalist at the Panelists Games, and I worked out twice a day. I thought I was invincible. Plot twist. Like many, I believe this illness happened to other people. Didn't happen to me. It would never happen to me. That's what I was thinking. So when the doctor first told me that I had prostate cancer and that it was slow growing, I thought I had time. I thought I had a lot of time. But within a year, my PSA levels doubled. Surgery followed in March of 2023. More surgeries as the cancer spread. I realized that cancer didn't care how strong you are, how fit you are, or how well you're prepared. It humbles you. I remember when I received the information about the cancer, I was driving and I pulled over. I pulled over in a parking lot. And I just sat there thinking, how was I going to tell my wife? And that day, I don't even really remember how I even got home. I think, I just automatically just drove. And yet, in the midst of that, it caused something to stir up in me because I heard about cancer for so long with so many people. I told myself I wasn't just going to sit by and watch this happen to me. I was going to make a difference. I had to figure out how I was going to make that difference. Today I share my story because I want to save lives, and that's any way that I can. I tell men, and this is ironic, I tell men no matter where I am. I was coming to the event in the airport, just talking to a gentleman, and we're pulling our bags, and we just talked to him, and I said, "So you got checked? Have you been checked?" And he just looked at me like, "Check?" I was like, "Yeah, for cancer, PSA, you check?" "Yes, I go every year, blah, blah, blah." And it was like, so I was like, okay. So I asked him in the gym. I asked when I'm teaching self-defense classes, wax on, wax off. And I even asked over donuts. And anyone knows me, know I love donuts and Twinkies. So even over donuts and Twinkies, I'm always asking about cancer. Because early detection matters. Early detection matters. No matter how fit you are, it won't protect you from cancer. But awareness and detection will. And that's what I'm trying to get across to everyone that I speak to. Go in there and get tested, no matter what it takes. And when I'm in the gym, everybody, trying to be swole, they don't want to talk about it, but I'll say, go get tested. And then the next day that I see them again, I was like, "Oh, and the guys will tell me I made an appointment." So that's, I know I'm doing something right. I learned that cancer doesn't connect us in suffering. It connects us in the fight and the hope. And by changing your perception of cancer, you can change your life. As various opportunities present itself, every moment, every day, every hour, every second, I'm always trying to communicate how important early detection is. As I go through, and in conclusion, as I go through the day, I remember why I'm here, is to help the next man, the next person, to get early detection, to hopefully can save their lives, and to change their perspective, because when people hear the word cancer, they automatically think death sentence. They automatically, and that bothers me, because when people find out I have cancer, "Oh, I'm so sorry," and that doesn't rub me the right way. So in conclusion, I always like to leave people with the words of Dr. Wayne Dyer. If you change the way you look at things, the things you look at will change. And that's what I like to leave you with. Thank you. I try not to cry. Thank you. Thank you. Thank you. Thank you. Now, please join me in welcoming the moderator of our next panel, Dr. Carmen Guerra, who is a professor of medicine, biostatistics, and epidemiology, and vice chair of medicine at the Perelman School of Medicine at the University of Pennsylvania. She has focused on developing and evaluating interventions to increase the participation of populations in cancer screening and early detection programs. She is a prior member of the National Board of Directors for the American Cancer Society and a recipient of the prestigious American Cancer Society St. George National Award in 2017. Thank you so much. And I just met her, and she is fantastic.
Good morning, everyone. Thank you, Russell, for sharing your very touching and moving story, and for your dedication to improving the lives of others through your advocacy. We are so much better today, this morning, after hearing your wonderful story, and we recommit to our shared mission to reduce this disease in our population. Before I introduce our speakers, I want to point out that there are microphones on the two ends of the room that we will use for questions and answer at the end of our panel session. And I will let you know when it's time for us to come to those microphones. For the online audience, I would like them to also submit questions through our panel, to our panel through the question and answer box, and we will share those questions with our panelists. And lastly, please know that the full bios for each of the speakers are available in your folder. So with that, it is my honor to welcome our panelists to the stage. Please join us. First, we will invite Dr. Preeti Bandi, who is the Scientific Director for Cancer Risk Factors and Screening Surveillance Research at the American Cancer Society. Her team produces the biennial Cancer Prevention and Early Detection Fact and Figures. Her research takes an interdisciplinary lens, combining work across surveillance, health services, and policy. Her studies patterns of cancer risk factors and preventive behaviors, screenings, and how they relate to evolving patterns of cancer incidence and mortality, always with a focus on social inequities in these outcomes. Welcome, Dr. Bandi.
Thanks for having me.
Next, I would like to invite Dr. Dorado Brooks, who is the Associate Chief Medical Officer at the Screening Business Unit of Exact Sciences. In his role, he provides medical insights to product discovery, development, and he works across multidisciplinary teams within the organization to contribute to the design, conduct, and reporting of innovative research. And he also serves as the liaison for the scientific-driven engagements. Dr. Brooks also works closely with the Exact Sciences Health Equity team on strategic outreach and collaborations designed to increase cancer screening and improve outcomes in vulnerable populations. Welcome, Dr. Brooks. Next, I'd like to invite Dr. Chaik Daubeny, who is Professor of Medicine and the Klotz Chair in Cancer Research and the Chief Health Equity Officer at The Ohio State University Wexler Medical Center. He is also an Associate Director of the Comprehensive Cancer Center. Dr. Daubeny is a clinical epidemiologist whose research focuses on improving the care continuum related to disease prevention and screening, with colorectal cancer as his model. He has led major studies demonstrating the effectiveness of colorectal cancer screening, as well as the harmful variations in quality of cancer screening, as well as the lack of appropriate follow-up for abnormal screening tests and health system and societal barriers to care. He also served on the U.S. Preventive Services Task Force between 2017 and 2021. At the U.S. Preventive Services Task Force, he led work to transform the recommendation development through a health equity framework. Welcome, Dr. Daubeny. And lastly, and not least, I'd like to welcome Dr. Philip Grainer, who is the Senior Director from the Theranostic Solutions, NAM, Molecular Imaging at the Siemens Healthineers. His expertise lies in integrating cutting-edge diagnostic and therapeutic technologies to enhance precision medicine, optimize clinical workflows, and improve patient outcomes. Dr. Grainer has dedicated his career to nuclear medicine and molecular imaging, particularly in the development and implementation of theranostics approaches that combine advanced imaging with targeted therapies. Welcome to you, Dr. Grainer.
Thank you very much.
So I'd love to begin with some questions for our panelists, and we'll start with Dr. Bandi. So Dr. Bandi, the ACS recently released the latest edition of the Cancer Prevention and Early Detection Facts and Figures. And this is a report on how the U.S. is doing on key cancer risk reduction and behaviors. Can you give us a state of play of what cancer screening rates look like today and what this means for screenable cancers? And lastly, can you tell us where are we making progress and where do we still have challenges and work to do?
Thank you for that question, Dr. Guerra. So, as you mentioned, we just published the Cancer Prevention and Early Detection Facts and Figures. It is this report. You can all access it at cancer.org/statistics. So you're right, there has been improvements, and there's also a lot of work to do. This report documents the data on that. And when we talk about screenable cancers, I'm going to focus on screening for breast, colorectal, cervix, and lung. So let's start with some of the good news, right? During the COVID-19 pandemic, we documented these declines that happened in breast and colorectal cancer, largely because there were disruptions in healthcare during that period. The good news is that for breast and colorectal cancer, the rates have rebounded and even surpassed pre-pandemic levels. And especially for colorectal cancer, this continues a long-term trend of improvements in levels of screening among age-eligible adults. So as of 2023, about 62% of individuals who were eligible were up to date for colorectal cancer screening, and about 69% were up to date with breast cancer screening. And the estimates I give you would be according to the American Cancer Society guidelines. And you can get estimates according to the USPSTF guidelines at the report, the CPED report, right? Now, what is not so great? Cervical cancer screening also declined during the pandemic. And the bad news is that it is not back to pre-pandemic levels. It remains low. Only about 76% of women were up to date with recommending cervical cancer screening in 2021. And why this is concerning is we are also documenting in our team increases in cervical cancer incidence, so new cases among women who are 30 to 44 years old. So that's something we're watching out for. And finally, lung cancer screening. It was first recommended in 2013 by the USPSTF and the ACS. Fast forward a decade, in 2022, we see that only 14% of age-eligible individuals, or rather it's a high-risk population that is recommended for, are up to date. And this is according to the ACS guidelines. It's about 18% according to the USPSTF guidelines. So a lot of room for improvement in lung cancer screening. And finally, I will mention the differences across the subpopulations that make up our country, right? We see distinct and persistent disparities by insurance status, by socioeconomic status, race and ethnicity, and even by age. So that's something we've documented in depth in the report. And I can speak to that more in a bit. Yeah.
Thank you. My next question is for Dr. Daubeny. You've spent much of your career looking at the continuum of care and how disparities in access to quality screening and follow-up can lead to disparities in cancer outcomes. Can you help us paint the picture of how delivery of these services actually occurs and how it is contributing to the statistics that Dr. Bandy just pointed out?
Well, thank you, Dr. Guerra, for the question. I want to thank the ACS and the sponsors for organizing this. It's really important, especially at this time. First of all, I'm from the Ohio State University Wexner Medical Center, but I'm a family doc, and I spent much of my career studying cancer screening and delivery. I put it in that way because the two things go together. I'm going to deviate for just a second because I want to make a pitch for one thing going on Dr. Stan's presentation. At AACR, a presentation was made and unveiled the study that was looking at one-dose vaccine for cervical cancer, which I think is transformative. It's really important because it's about prevention as well as screening, detection, right, the follow-up. And we spend a lot of time now at the American Gastroenterological Association. I know ACS, you've been on this for many years. ASGA, which is also GI Society, with primary care. The reason I say this is because screening is not a single thing. And if it's done as a single thing, it doesn't work. It will work. One screening is better than none at all. But it's a series of steps that are involved. You get screened. If it's negative, then you get screened again. If it's positive, what we've shown is that your risk of dying from colorectal cancer, if you're not followed up quickly, within 3 months, as a matter of fact, goes up by 10-fold in some estimates. The one we published around 7-fold increased risk. So in the real world, it's very chaotic. Cancer screening is, I describe it as very chaotic. There are very organized systems like Kaiser, which I've been fortunate to study, because they look at those who are eligible to screen, and that's important because we wait for people to come to us. The pap smear, wait for people to come to us, we examine them with a physical exam. Now we're going to do self-sampling, right? Which would be great when we get to that point. And thanks for your work on that. And that's really important because people without access, without insurance, to pretty to your point, if you don't have insurance, you don't have regular place of care, invariably it means that you actually can't get that preventive care. And many of these people also live in areas where there's not enough of resources there for prevention, exercise, physical activity, and access to smoking cessation. That's really number one killer in my view. And so that's really important. So our process of care involves people coming to us, right? In the busy clinic that I see, I'm fortunate to be in a very simple system. Cancer screening doesn't seem to rise to the top. Let me give you another issue that I think is really important for us to pay attention to. If we don't measure something, it doesn't get attention. Lung cancer screening doesn't get measured currently, and we need to measure it. Follow-up care for cancer screening doesn't get measured. And so I know we're going to get to these issues, but for many of the populations that I believe we're all really concerned about, have issues getting to care. Rural areas travel long distances in Colorado, Ohio, in Arizona, anywhere, Texas, you look at miles and miles and miles to get screened. And if it's positive, miles and miles and hours to get the colonoscopy. There are no colonoscopists in those areas. In Louisiana, we looked at those areas. There are deserts there, people who need colonoscopies that they don't get done. Nationally, the follow-up rate that a study published out of Optum is 56%. That, to me, is actually a good number. If you look at federally qualified health centers, I bet you, would love to look at, I bet you the numbers are probably going to be 0 to something. And Kaiser is about 80%. I think that is unfortunate because if you give screening to somebody and you don't provide a follow-up care, in many ways, the way I see it is this. It's just very simple. You're given a teaser. When the actual need comes, they can't get access to it because that's what really makes a difference. Medicare made a big change for colon cancer, and hope will sustain that. We need that to actually propagate to other cancers so that when you get that second-tier level of care, you don't get burdened with a pre-approval that Lisa talked about and other things. Because that is really the financial barrier that gets in the way. But lastly, Carmen, before I hand off, is the concept of access. I want to talk for it for 1 second. Access is very complicated. Giving insurance to somebody is one big step. I think it's really essential, but it's not enough, right? You have to have the services available, hopefully near you. They have to be acceptable to you. People's values and preferences matter. And I think especially now we need to pay attention to those values and preferences. It needs to be affordable. It's not just about costs, the opportunity cost of getting to screening, leaving your job to get a colonoscopy, get that lung cancer screening done, right? And so there are a lot of these things that are really important for us to pay attention. And ACS, thank you, Ken, thank you for doing this work. But what my plea is that we need to have systems provide that access to screening that is not predicated on having solely on having a visit to the clinician. Is the only way that I see. It seems like a mountain that we can get to address these barriers. And having Medicaid shouldn't mean that your rates of screening should be lower, right? And so these are areas that I think is really important. But prevention is key. Thank you, Stan, for saying that.
Thank you. Thank you so much. Excellent points. Dr. Brooks, the average person may think of screening as their mammogram or their colonoscopy, but those singular tests are not all that's needed to be able to complete screening. Given your extensive experience with colorectal cancer screening, can you talk about the challenges with screening completion and follow-up testing?
Sure. Thank you, Carmen. And again, thanks to ACS CAN and the organizers for putting this panel together and allowing me to participate. I spent 20 years with the American Cancer Society before joining Exact Sciences, and I never got to attend one of these because it's always a very tough ticket to get. So it's an incredible honor to be here on this panel. Actually, Shaik has touched on a number of the points that I had intended to make, as did actually our opener, Mr. Wright. One of the biggest challenges prior to going to work for ACS, I actually practiced primary care medicine for about 15 years. And I can tell you that when I talk to patients about cancer screening, very often the perception was just as he mentioned, and that is, why would I get that test? You're going to find I got cancer and I'm going to die. So the idea that cancer screening can help find cancer at an earlier stage when it makes a difference in outcomes, or even more importantly, that some kinds of cancer screening can actually prevent the disease. That's a foreign concept to many patients, and unfortunately, I left practice 20 plus years ago, and yet it remains a foreign concept. We have to do a better job just educating patients about why screening is important for them and how it can have a positive impact as opposed to just being this scary thing. So that comes to just the importance of education and awareness for patients about the value of screening. Another important issue, especially as it relates to colorectal cancer, is the fact that, unfortunately, for many primary care providers, and again, I was a primary care provider, I understand, and the pressures 20 years ago in primary care are nothing like what they face today. And trying to balance all of the different demands is a huge challenge. And consequently, there is oftentimes a tendency to kind of take the easy path. And when it comes to discussing something like colorectal cancer screening, the shortcut is, it's time for you to get a colonoscopy. And they write the order and they walk out of the room. Again, no explanation to patients as to why that's important, and also no discussion with, what do you know about colonoscopy? Are you willing to have the test? What are your fears and concerns about it? Because there are a lot of patients who, even if they have access, aren't willing to undergo colonoscopy. And then there are a whole nother group of patients for whom colonoscopy access is limited or non-existent based on income, education, and a variety of other things. So starting with that education point, making sure patients are aware that there are a number of different tests that they can use to screen for colorectal cancer that are all recommended in guidelines and proven to be effective, that can change the course of the disease and, in most cases, can even help prevent the disease. And studies have demonstrated that when patients are educated about options and given a choice, they're more likely to follow through and complete their screening. But unfortunately, that's often not the case. They just don't get that information. And then finally, patients should be informed, and Chaik has mentioned the fact that screening is not a one-step process, and that's really for any of the screening tests that we do, but particularly for colorectal cancer screening. If patients do choose one of those non-invasive options, then they need to understand going into that if you have a positive finding, you absolutely must complete that colonoscopy for the reasons that Chaik discussed. You are now identified as being at much higher risk, and yet we, as a healthcare system, often are paying little or no attention to that very important follow-up piece. The same study that Chaik mentioned that found that only about 56% of patients who had a positive finding on a stool test completed their follow-up colonoscopy. In that same study, those investigators talked to primary care clinicians who were taking care of those patients, and all of those clinicians had the perception that just about every one of my patients who has a positive finding, yeah, they get their colonoscopies done. Of course they do. They think that because they know it's what should be happening, and because there is no measurement right now. There's no tracking and following up to let them know, no, you're doing a really lousy job of getting that extremely important follow-up exam. So I'll stop right there.
Thank you. Thanks, Dr. Brooks. Dr. Grainer, lung cancer is the leading cause of cancer deaths in the United States. Progress has been made with new treatments, but the progress based on screening has yet to be realized. Can you talk about lung cancer screening, how it came to be, and the challenges that we are facing today for increasing lung cancer screening rates?
Absolutely. Thank you very much. First of all, although thank you very much to the ACS for the invitation here, as it's very important for us as a medical device company also to be part as often early screenings for patients with imaging. Lung cancer screening really marks a tremendous shift in how we approach medicine. In the past decades, as we heard before, also hear from colleagues and panel members, it was more a reactive care than proactive care. And this is really something where we first needed to see symptoms to actually treat, or even the diagnosis then trigger treatment at all. This changed, especially for lung cancer in the 60s, where imaging was discovered as being able to catch disease at a way earlier time point. We were able, first with X-ray and also then sputum cytology, to detect lung cancer earlier. But it was unfortunately still not early enough, and the mortality rates were still very high. The real breakthrough came with low-dose CT in the late 90s, where we then had, through CT imaging, the possibility, and through different clinical trials, the opportunity to really detect cancer maybe already at stage 1, where we then were able to treat and see also a way better treatment outcome of those patients who were diagnosed earlier. It took many, many more clinical trials and more time until 2011, where really then low-dose CT was in the guidelines for lung cancer screening. Dr. Bundy mentioned already, it's already a decade, but we're still not doing a very good job on screening lung cancer patients. Even there's the clinical evidence. Even so, we have reimbursement. It's really only 10% or 14% of patients who actually get screened who would be eligible for lung cancer screening. There's a lot of boundaries out there, and for us in the medical technology field, for us as Siemens Healthineers, it's important that we need to partner up, because we know all the boundaries out there, as we mentioned already, access to care, even easy things like, hey, I have to take a day off work, which seems to be easy for us, but is a huge hurdle for some people in underserved or rural areas out there. So how can we as a medical device company partner up, build trust, and do community outreach together with our customers and partners? We know that just providing the cutting-edge technology won't help. So we really have to go in those deep partnerships, provide the technology, and bring the technologies to the patient. A really good example is a partner with us who received one of our mobile trucks for low cancer screening CT in rural Tennessee. There was a high rate of lung cancer, and it was normally a death sentence for those patients diagnosed in this community, in this rural community in Tennessee. We had the opportunity to bring the mobile bus out there, and again, it's important that it's not just a one-time event. We really have to have a whole idea and network after that. Patients get screened, they get diagnosed, but then also all the treatment, the follow-up, survivorship needs to be all completely designed there as well. So we were able to go with our partner out there in the middle of Tennessee. We screened patients. We worked very close with community leaders to get also people in to get screened, to get the stigma and nihilism away, and really the fear of having cancer, and cancer being a death sentence as well. Now we have actually the first time in this small little town in Tennessee, cancer survivors. People survived lung cancer, and those are now our biggest advocates out there. They talk to their family members, they talk to their colleagues, they talk to people in the gym, and just tell them, hey, get screened. So this is really important for us also to see in a very good example that we need to be proactive in medicine as well, and that we need to be proactive also in the field of imaging and outreach to patients and access to care.
Thank you. In all of your responses, you've all mentioned some limitations related to data collection, cancer screening data collection. And I wanted to revisit that because it seems to be very closely linked to our ability to make progress. And when I think about data collection, I think that maybe that's something we could fix in the near term, rather than waiting for some long, perhaps new discovery. Perhaps this is a way to move forward. So I wanted to go back to each of you because you've all mentioned data. For example, Dr. Delbany reported on data related to completion of abnormal cancer screening tests. Dr. Brooks, you mentioned data regarding completion of an average cancer screening test completion as well. So if we could address the data question, beginning with you, Dr. Bandy, what would that be for you?
thank you, Carmen, for, oh, is it you?
Go ahead, you can start, Deb.
No, you. I got excited about it. Can you tell?
Yeah, not as excited as me, I think. I mean, yeah, I mean, you can tell I'm an epidemiologist, right? With how fast I wanted to respond to the question on data. But yes, so I want to make 2 points here, Dr. Guerra. One is the centrality of these large federal data resources that we have available as epidemiologists who do cancer surveillance, and the importance of them for tracking not just cancer screening, but cancer burden like incidence and mortality. And so the data that I presented earlier, they rely on the National Health Interview Survey. It's a nationwide survey. The Behavioral Risk Factor Surveillance System, this is a state representative survey. And I say representative, the beauty of them is that they are generalizable to the US population, something that a lot of other data sets don't have. For measuring cancer incidence and mortality, we rely on national and state registries. All of these are funded and supported by the federal government. And I just want to take this opportunity to reiterate the importance of ongoing routine data collection to track cancer burden, and the importance of preserving these data sets and, if not, improving them, right? So that's just one point. The other point I wanted to make is how do we make these data sets better and what we could potentially do to make them better. In terms of the how, one of the big concerns we're having with tracking surveys is dropping response rates. So right now we have, for the NHIS survey, response rates are less than 50%. And when that happens, it really impacts our ability to track differences in subpopulations. Because people who don't tend to respond, they tend to have, be off disparate populations. So it's important for efforts to improve these data sets to focus on improving response rate, getting more responses from historically marginalized communities. The second point is what do we include in these data sets, and it really gets to what Dr. Durbany and Dr. Brooks talked about, and the idea of screening being a continuum, right? It's not just getting screened and done. You have follow-up, you have indication, you have quality. All these go into making a screening successful. And these are unfortunately not very well tracked in the data sets that we have. Now, we have to keep in mind respondent burden when you ask people questions in these surveys, but maybe innovative linkages with other data sets that track these routinely and accurately would be something to explore so that we can actually get to the factors that make the whole screening continuum work. Yeah. So those are my thoughts.
Thank you. Dr. Brooks?
Number of different things. For one, as I mentioned, there's currently no measuring of what happens after a patient has a positive finding on a stool test, abnormal stool test, or a non-colonoscopy screening test. And fortunately, there is actually a group looking right now at creating a HEDIS measure for the follow-up colonoscopy. I can tell you, I've been in colorectal screening a long time, including back before Medicare even paid for screening. So Medicare payment for the full range of colorectal cancer screening was a huge issue and jumped the field forward, but maybe not as much as the creation of the HEDIS measure. When you put that measure in place, suddenly health plans and clinicians and health systems all really started paying attention, and we saw some dramatic positive movement. So I'm hoping a HEDIS measure related to follow-up colonoscopy can have a similar important and valuable impact. I think it's also important that we look at the data that we have available to help us steer. Everybody gets very excited about innovation and new tests, and certainly there is a lot of excitement, but I think Dr. Lapidus, in his opening remarks, gave us a little caution regarding the rapid adoption of new and emerging technologies. As he pointed out, we have blood tests available now for colorectal cancer screening. In full disclosure, Exact Sciences is actually in the process of developing our own blood tests for colorectal cancer screening. But our approach at present is we're looking at this as a second-line option for screening because of the data that Dr. Lapidus shared and the fact that everyone who's talked up now has talked about the importance of precancer and prevention. And with colorectal cancer screening, if you find the precancers, you can help prevent the disease. These blood tests, they do they do actually a very good job with later stage disease. They do a fair job, I believe he said 60% or so sensitivity for stage 1 cancer, but their sensitivity for precancers is very low, only about 13%. And there have been a couple of modeling studies that have looked at this now and determined that if we start replacing current state-of-the-art guideline recommended test with blood testing in patients, because again, it's potentially that easy button for patients and providers, we actually have the potential to move backward to hurt population health and public health. So we need to be careful in moving forward that we're sensitive to what the data tells us.
Thank you. Dr. Dahlman?
I couldn't wait, right? No, thank you. And I'll put a plug in for a paper that both Dr. Dorado and I are co-authors, and thanks to Exact for championing that showed that if you address, this was 2 issues that Carmen you got to, which was if you address in colorectal cancer screening, the quality of screening is measured. One of them is adenoma detection rates. So those rates are lower in Black people than other groups, and probably African American, Native American groups as well. But also follow-up rates are lower. So if you are able to close those gaps, right, in follow-up and quality, you improve expectedly the life expectancy and outcomes for the groups. And I think one of the points to make is how can we get to the best rates? If we say the best rate for colorectal cancer is 9 per 100,000, right? Can we get everybody there? What difference would that make to the cost of care for people? So can I put in a radical idea?
Sure.
So this is an idea that we've been floating around. We have registries for SEER registry. I mean, so, and what that does is phenomenal. And it hasn't gotten us to the populations that are not well represented. So Native American population, rural population, because these are areas in which we need more data. But I think if we begin to work on that, we can get there over time. We're in the age of AI, right? I mean, I get in my car and I tell it I'm going to Los Angeles to tell me where to stop to charge. And it's actually pretty good, except when I get there, I have to wait if someone else is in the charging station. But that is a different story. It also tells me to go somewhere else if I need to do that. We're in the age of AI, and I don't see why we cannot track people's screening experiences in a form of a registry. I think we've gotten past some of the kind of worries about data, and I do think that one of the things we are suggesting is to have a screening registry. This is what it will do. If you go and see Dorado and you come and see me, the EHR is much better. So there's care everywhere in Epic that tells me you've been somewhere, but I still have to look at it. And the integration is not perfect. But it gives us a way to download that information as we do for immunization records into our own charts. And so that allows us to be able to understand people's screening rates in health systems that I think is probably next step from surveys that NHI is a great source of information. But also it allows us to see, whether people are getting follow-up. The way Kaiser system works, right? It's beautiful the way it works. They have a reason to do so. They're insured, they provide care. They have a reason to want to make sure the populations are healthy. What do? They track everyone. Track is maybe not the word. They monitor everyone to see if you're up to date on screening. They reach out to get screened. Once you're positive, what do? They send you directly to the endoscopies department, who takes ownership of you until they make sure, like Hero, right? Until you're satisfied, I'm not going to let go. So they make sure that you get that colonoscopy done. If it's not done, document why it wasn't done. And their goal is 80% within 6 months. Our studies showed in the 3 months to 9 months is probably that gray zone. I'll say anytime you wait is too long. But I do think that having some form to collect data and paying attention to the populations in rural areas that are underrepresented, looking at demographic groups, because how do you know where to improve? You have to look at the populations that are doing worse. Whether this is by race, socioeconomic status, insurance, geography, or other areas, we have to be able to look at that data across that, and across the continuum from being eligible to getting screened to getting the follow-up and cancer treatment. Because if any of these things don't happen, we've done a great job by telling you got screened, wonderful, but it didn't get treated, didn't get a follow-up care. It doesn't work. So great question. Again, ACS Can, I know you do this work. We're just putting a plug for you. Thank you for what you do.
Thank you. Dr. Grainer, a question about data for you. Data.
Data is very important for us as a medical device company, of course, not just for the screening event, but also for the complete care pathway, and to really be also able to create then, based on this data, AI in different areas. For example, with a low-dose lung cancer screening CT, if you have the patient already once in the scanner, all of a sudden we would be able to provide not just lung cancer screening, but we can also look at your calcium score, we could look at the aorta, we can look at the bone density. And this is only possible by collaborating with institutions to collect data to train algorithms. So the data aspect in the whole screening amount is for us as a medical device company very important too, to be further develop technology. But again, in the end of the story, not just the technology is the important part and collecting the data, but then also bringing the data or the technology to the patients. It's really something where we learned in the last few years as a medical device company, it doesn't help to just collect data, use the data, or drop then new technology with our partners. It's really important to team up, to build this network, and to be able to also successfully use data in different areas in the medical field.
Thank you. Wonderful. I'm going to go through a third round of questions, but I'd like to invite now our audience to come to the microphones to begin to ask their questions as well. So I'd like to start with Dr. Bandy. Dr. Bandy, you earlier alluded to differences in the data by subpopulations, and I wonder if we can go back and revisit some of that information. I know that sometimes when we see overall rates, they don't really paint an accurate picture of what's going on with all of those subpopulations. Can you expand on that for us?
Yeah, thank you for that question, Dr. Guerra. So, it's not new, this information, that there are widespread and persistent differences in screening uptake and cancer risk by many social factors. We've been documenting it in the facts and figures reports. The CPED report I spoke about earlier also gives you screening rates by differences. So I'll talk about those that consistently show up as being important and persistent, right? So no-brainer, insurance status, the insurance type is very important. So what we are reporting is that, in 2023 and for many years now, those who are uninsured and those who have public insurance, like Medicaid, they tend to have much lower rates of screening compared to those who are better insured, like those who have Medicare or private insurers. So, for example, rates are up to a half to a third lower among those who are uninsured for lung cancer screening and colorectal cancer screening, right? And these differences by insurance status really, drive for the most part disparities you see by other social factors like socioeconomic status or race and ethnicity, right? Because that is a key determinant in the healthcare structure that we live in, right? So by race ethnicity, we see that Native American people, including American Indian and Alaska Native individuals, Hispanic individuals, Asian individuals, they tend to have lower levels of screening compared to their other counterparts. And in terms of socioeconomic status, of course, lower income and lower educated people have lower levels of screening, right? Another group we've consistently identified are recent immigrants. People who come to our country recently, they have some of the lowest levels of screening, making them at a high-risk population. Apart from their, moving here, they seem to be at a higher risk for not accessing health services that are important. And finally, we are noting much lower levels of screening for younger people compared to older age eligible counterparts, right? And this is something we are continuing to monitor because, as you all know, and Dr. Kamal will talk about it later, right, about young adult increasing levels of cancer and cancer risk among younger people. What we're noting is that screening levels are also very low in these age-eligible younger people compared to their older counterparts. So that's another disparity that we've identified that should be monitored going forward.
Thank you. Dr. Daubeny, can you expand on the documented barriers, but speak of them as groups of barriers at the patient, provider, system, and policy levels?
No, it's actually made my job easier in the prior presentations, and that anyone who's heard me speak about this before would start many of these conversations by saying, I think we need to actually address the systems that create the care and the care design before we address the individual issues. And let me sort of maybe go in a little bit why I say so. Let's work on a patient, maybe you want to take one of my patients, doesn't have transportation, could be living in Columbus, Ohio, and you may say it's an urban area, why do you bother? What about the last mile, right? So to get to their home from the bus stop or wherever it is, it's not as easy as it seems, right? Or maybe they have patients' family at home, a grandmother looking after their kids, grandkids, and have to provide daycare to get to screening. Or they're just afraid, to the point made earlier, to get that cancer diagnosis, right? We heard a story from Russell about that cancer diagnosis. I just told a patient this week that she has most likely lymphoma, right? And I'm saying to myself, how is she feeling? If she doesn't know, she's blissful, right? Now she has a diagnosis and we have to work through it, right? Early detection is important. So the fear is real, the cost is real, and every other thing, the acceptability of the screening test, whether it's low-dose CT scan, a colonoscopy, or just stool tests, all of those are real. When it gets to sort of interpersonal levels, the relationships stigma, the fear that you're going to be told again you should quit smoking, right? Will be sort of making you feel like, do you want to go have that conversation to be told I need to quit smoking by the 10th doctor, as if I don't know I need to quit smoking, be told you're a smoker and you have COPD, and all of that. That is real. The fact that you're in a community that doesn't have, a specialist, the pulmonary specialist to interpret if you're not using telehealth, or have colonoscopy resources is real. All of those are real. Now, I talked earlier about the design of our care, right? You have to get to a doctor, right? And you have to get an appointment to get there. And the system we design, I don't want to go too far into that space. The way we design the systems is such a way that it's actually not that easy for anybody to access. So if I get agencies to that patient to get to the system, Errol Friedman that's the origin of patient navigation. People got there to see people coming out of the hospital. If you get there, you're going to come out a dead person. So why go figure out if you have prostate cancer, right? And so I think if we don't have our systems in order to receive people, make them feel welcome, give them access to the test, the follow-up, they see a roadblock, and they tell their friends and others. So insurance is important, but it's not the only thing that will get people screened, right? And so insurance is important. We can't let up. Medicaid is an important source of life support, as a matter of fact, for many people beyond cancer screening. And the Affordable Care Act or other things that have been done to provide access to USPSTF is important. But I do think we need to work on how the insurance designs and all of those things and the policies allow people, stand to your point, allow people access to screening and the follow-up care. Because without that piece in place, you can drive to that water and find that it's actually not drinkable, right? Anybody been to the bad waters of the Death Valley? The donkey said, no way, I'm not going to drink of that water. But actually, in this case, there's a glass wall there that says you actually can't even sniff it, because when you get there, the glass wall there. So I would employ us to think in that way, but we can't just be stuck in one level. We have to work all levels, just like anything in life. It's always a continuum. But I do think the systems without being in place, often people get there, and that creates experience that I'll call as, oh, they don't want to get screened. I think differently. They get barriers that tell them that if they get there, you're not going to get it. So they're saying, why should I then do it, right? And so this is my way of thinking about it, and I think it helps me see patients' barriers as problems we solve, as opposed to patients solving those barriers.
Thank you. We have about 5 minutes left, so again, I'd like to invite our audience to ask any questions that they might wish to ask, and thank you for that.
Hi, so I'm reading from the internet, so a reminder, you can use your online portal to submit a question. I think this is quite a good one. How can AI be utilized appropriately to deliver faster analysis of data and screening follow-up?
Who would like to take that?
I can try and have a start with.
Sure.
So what we really try with AI is to have very quick turnarounds and black and white results to patients, because sometimes we even don't have opportunity to follow up with patients. If they're in a mobile truck getting scanned for lung cancer, it's very important that we get results as soon as possible. So with AI, we are able to detect any lung lesions in seconds after the imaging was done. Radiologists can remotely look at those AI results, and then we at least have a first opportunity to right away schedule the patient for some necessary follow-up. So in this case, really AI helps to just give results way faster to the patient, because at some regions and some areas, we don't even know if we ever will see this patient again. So this is really important that we have an immediate follow-up and need to schedule follow-up if necessary as well.
Thank you. We have another question in the room.
Hi, so Dr. Dubeni and Dr. Brooks kind of covered the challenges that we face in the colorectal community with the advent of non-invasive screening tests, but then needing coverage for follow-up colonoscopies. As we look to the horizon of MCED tests and wide access of these tests, what lessons learned would you share with those working in this space, and what concerns do you have as far as access to follow-up screening for these tests and potential disparities that may come with limited access?
That's a great question. I'll start. I'm sure Chike has something to contribute as well. But I think one of the basic issues is that for non-invasive testing for colorectal cancer, the follow-up colonoscopy was sort of an afterthought, and there wasn't a lot of attention paid to that really for the first decade of growth of stool testing. And then it's kind of like we looked and, oh, wait a minute, we have a problem here. So I believe that all of those who are working in the MCED space are very aware of the need, and all of the trials are incorporating that follow-up piece. I think the trials are trying to be designed in a way to be much more inclusive and making sure they're including populations who traditionally have barriers and challenges, so that even in the course of the clinical trial, they're attempting to figure out what are the best ways to get patients navigated to that follow-up piece. But ultimately, it's going to come down to payment. And that's why the bill that was discussed earlier is going to be so important, making sure that we've got payment, not just for the initial test, but that follow-up piece is included in that, because that's been another big issue and challenge for the follow-up colonoscopy.
I know some of us, including Dr. Guerra, were involved in the design of the Vanguard study that's currently in the field. And I think going back to Stan's points about the need for the hard outcome of mortality as a preventive services guy, I'd say that's the standard. But as a pragmatist, we have some middle road to go somewhere, right? I think the evidence is still involving. I think the question is really important. I think the industry is aware of it, but pragmatics of finances and money and venture capital dictate sometimes otherwise. My plea, and have turned this to a plea, is that, and I've said this to, I've been involved in this MCEDS conversation since about 1999 or sometime around there. It's not 2000, can't remember when, 2019 or some date. is that we build this out as a pragmatic study, right? So that we're studying as we're rolling them out so we can learn on how, because a lot of the evidence to Stan's point was built on observational studies. The trials on colonoscopy are just coming out, and so there's some fairness to that. I think the challenge is for any MSED, if it's positive, what does it mean? So Exact Science kind of gone the route of we do a PET CT, right? Look at your whole body. There are all these questions of incidental things that you find. Who takes care of them? Who pays for them, for that care? If you have a tissue of origin, that's a signal of origin that you can identify, ensuring that that can be built into the care process is important. So I think it's having all of that mapped out, and I think we've done a good job of mapping that out. NCI has done a good job of mapping it out. And so it's a matter of being aware that this is really an important piece of it, because if we do the screening, and if we had 1 more hour, I'm sure this is a conversation 1 more hour, but Exact says that, oh, great, so I've done the screening, my job is to provide screening. Do I have a responsibility as a company to ensure that you get the follow-up care? The answer probably is no, right, because of all the regulations there, but whose responsibility it is to make sure that, because to you, once you've done the screening, you collected your stuff, and you out of here. The patient, the journey just started, right? So I think that's a piece that we have to keep in mind to figure out who has that responsibility and how do we assure that the systems are in place to do that. I don't think we're there yet because the evidence isn't quite there, except even for Guardant's Shield. The evidence isn't quite there that these are the tests we should go to. At the same time, if we make that approximate more approximately in identifying precancers earlier, then I think we're in a place where this will become more and more important, because you're talking about now colonoscopy for potential lung, then CT scan, PET CT for lung cancer, and what else is there, right, after that? Well, thanks for the question.
Thank you.
Well, thank you all, and I want to have our audience join me in thanking all of our panelists for a very informative session.
Even as our AI, we don't deploy our AI if the institution really does have a plan for incidental findings, because it doesn't make sense.
We will now have a 10-minute break, but please be back here to join us for our next panel session that will start promptly at 11 a.m. Thank you. Is this on?
Good morning. So I hate to stop all these wonderful conversations that are happening, but we're going to begin with the next panel. So if I could have everybody come back in and sit down. So I think we can all agree that this morning's first panel was really dynamic and the conversation robust. We talked about the status of screening and some of the challenges that we're currently faced with. Next, we're going to take a look at what new innovations and approaches are happening and what's on the horizon. So please help me to frame this next discussion. Please help me welcome to the stage ACS CAN volunteer Kathy Ottele.
Thank you, Kristin. Good morning. I am honored to share with you today my cancer story. My cancer story journey began 27 years ago when my father died from pancreatic cancer. A few years later, I received a phone call at work, and it said, "Kathy, you have melanoma." I was diagnosed, treated, and cured in 21 days. My mother died from multiple myeloma, a diagnosis being made only a few weeks before she died. My younger sister, Pat, died from breast cancer. And 2 years later, my baby sister, who was my best friend in life, died from metastatic melanoma. As of last August, I am now a 7-time skin cancer survivor. I don't know about you, but cancer sucks. Cancer sucks big time. Through my volunteer work with both ACS and ACS CAN, I learned to tell my story. And I found that I was slowly healing from that horrible loss. I learned that I could fight back and definitely make a difference, not only in my community, but in the halls of Congress. A few years ago, I heard about a multi-cancer early detection blood test developed by a company named Grail. And it was being studied right at Oregon Health Science University in Portland, Oregon. I was so excited. I called them, and I was told I could join the study. It was called Pathfinder 2, right at Salem's Health Cancer Institute in my hometown. My appointment took less than an hour. They recorded my medical history. They took a blood sample. And 2 weeks later, I got a phone call, and the voice said, "Kathy, you have no cancer cells in your blood." Can you imagine how I felt? I just stood there in my kitchen and cried. As a Medicare recipient, I look forward to the day when I will receive a healthcare checkup and be told that the results of my MSCED test ordered by my physician shows I continue to have no cancer cells in my blood. I don't know about you, but I have hope. That hope is knowing medical research and technology are now so vital in the fight against cancer. I also have hope in the support being given by our elected officials who believe we can end cancer as we know it for everyone. Thank you for listening to my story. Thank you. And now, please join me in welcoming the moderator for our second panel, Rodney Gillespie, who is currently the Senior Vice President of U.S. Oncology, Therapeutic Area Head of Novartis Pharmaceuticals Corporation. He has the responsibility for U.S. Oncology, commercial strategy, growth, and the launch of solid tumors, hematology, as well as cell and gene therapies in the U.S. Before Novartis, he was Vice President of Sales and Marketing, solid tumor for Janssen Oncology, a Johnson & Johnson company, and spent 13 years with AstraZeneca. Welcome, Rodney.
Still morning. Good morning, everyone. Thank you, Kathy, for sharing such a touching story. The work we do is important work, and we do it for the reasons we just heard is to hear someone say, I'm cancer-free. Like, it's such a powerful statement. And I was listening to the panel before, and the physician was talking about how when you tell a patient that they have cancer, how hard that is. And, I've been fortunate not to have cancer, but I know, like a lot of us, we've been touched by friends and family with cancer as well. So a big thank you to ACS for inviting me to be a part of this panel, to be the moderator for this an important discussion we will have. It's really a privilege. And, at Novartis, it's our mission to improve and extend, patient lives. And we have a portfolio of cutting-edge medicines that we've been studying and bringing to market for well over 30 years. And our radioligand therapy is a unique innovation that we brought, but we also extended it to diagnostic in terms of helping to find the cancer in a patient's body so we can bring targeted medications to it to help cure and help get rid of that. But we know progress is more about how do you actually help to screen and diagnose and bring early detection so patients never do have cancer or they learn about it early enough to be treated. And so we continue to be committed to that each and every day in the work that we're doing. So what I'd like to do today is introduce a panel, a really distinguished panel of individuals that are doing amazing things. And before I talk about the specifics of the panel, for the past 6 months, Novartis, we've been reaching out more into the communities and really looking at partnerships. Partnerships being so important to us, and partnering with prostate cancer, or zero prostate cancer, partnering with the Susan G. Komen Foundation. We even did an amazing partnership with the NFL that we continue with, and where we introduced a sort of a new initiative called Your Attention Please around breast cancer. And so as we look at the partnerships of how do we get out into the community at a deeper level, I think these partners that I'm going to bring on the stage are individuals that are impressive in the work that they're doing in their local communities and throughout the country as well. So let me bring to the stage first Courtney Bugler, who is the president and the CEO of Zero Prostate Cancer. Good to see you. Courtney is leading progress in the mission and the vision around infrastructure, fundraising, advocacy as it relates to bringing cancer diagnosis to the forefront. And she's been doing this work for well over 20 years. Courtney has extensive expertise in advocacy, equity, and public health communications. So welcome, Courtney. I'd also like to introduce Tracy Lewis, who is the operations director of the Colorectal Cancer Prevention Network at the University of South Carolina, where she oversees a statewide professional patient navigation program that addresses health disparities to care in low-income and underinsured and uninsured individuals. Welcome, Tracy. Let me also introduce Dr. Dawn Mattoon, who is the CEO at Mercy BioAnalytics. She brings more than 20 years of experience in the biotech industry and has held leadership positions in R&D, strategy, general management for leading companies, including Introgen, Life Technologies, Thermo Fisher, and cell signaling technology as well. Welcome. And our last panelist, not last but not least, is Dr. Sarah Nosal. She is the president-elect of the American American Academy of Family Physicians. I got it right. The AAF represents over 128,000 physicians and medical students nationwide to help inspire positive change in the U.S. healthcare system. Sarah also serves as the Vice President for Innovation and Optimization and is the Chief Medical Information Officer at the Institute of Family Health, a federally qualified healthcare network with over 27 plus centers in Mid-Hudson, Bronx, Manhattan, and in the Brooklyn location. So welcome as well. Thank you. All right, let's just jump in. Dawn, maybe I'll start with you, actually. We've seen so many advances in cancer treatments in the field of screening and detection, and I want you to give us some insight into what are some of the new modalities for early detection that are on the horizon, and what does it actually take to bring one to the market as well?
Thanks for the opportunity to be part of this panel. This is an incredible forum, and I'm just honored to be here. And I appreciate the question. It is such an exciting time to be doing work in this space because there is so much investment that is coming into this space, and that is catalyzing an incredible period of innovation. We think about measurement of DNA, measurement of RNA, measurement of protein. The particular modality that we focus on is tumor-derived extracellular vesicles at our company. And it's just been an extraordinary period of advance. If we think just in the last year, we've seen FDA approval of an RNA-based stool test from Genioscopy. Just last summer, we saw, as Stan mentioned in his remarks, the Guardant Shield blood test for colorectal cancer screening was approved by the FDA. And just this week, we saw the first at-home cervical cancer screening test be approved by the FDA. And there is a wave of innovation that's coming along behind those. I think for me, the area that I'm most excited about, though, is in that 60% that Stan referenced, innovation in cancer categories for which we don't currently have screening. So the next thing beyond colorectal, prostate, lung, breast, cervical, and that's the area that we focus on at Mercy. Just to illustrate it, because obviously it's the space I'm most familiar with, we've developed an ovarian cancer screening test that will be for postmenopausal average-risk women, and in large studies in the intended use population have achieved 89% sensitivity for the detection of early-stage ovarian cancer at 98% specificity. And these results are truly unprecedented. We had an opportunity to evaluate our test on a head-to-head basis relative to kind of the next best marker, which is a blood-based marker called CA-125, and we're able to demonstrate superior performance. In addition, we were able to demonstrate that unlike CA-125, our test performs the same in white and non-white women, which is an incredibly important feature of any cancer screening test. So just to illustrate the advances that are happening in the science and technology front, I think the challenge I would highlight, though, to address your question about what does it take to bring these tests to market, we will be bringing our test into the market, early patient access, in the first part of next year. But that is just the beginning of this journey. And in certain ways, getting the science right, getting the clinical evidence right is the easy part. The more difficult part is creating expanded, broad patient access. And as a number of the speakers have alluded to, that requires that a test is covered by insurance, by Medicare, and then by private insurance. And I suspect we'll talk more as the panel goes on. Currently, there are only 2 pathways for getting a new cancer screening test covered by insurance. One is through the United States Preventive Services Task Force, which is imperiled in a few different ways right now. And the other, of course, is through an act of Congress. The multi-cancer legislation that's been referenced is an example of a bill that's moving through, but it's a much broader opportunity, I think, for us to create pathways to patient access to Medicare coverage for these really exciting, emerging early detection modalities. And I'm thrilled that the work of ACS CAN has become so strongly oriented around that. I think this is something that, as a community, including as companies who may compete in the market, this is something we can come together and work together to advance. So really excited to talk more about the specifics of how we might do that.
Thank you so much for sharing. We can tell it's not, I mean, it's innovative, but it's hard, right? It's really hard, but it's so important. So thank you. Thank you for giving some insight. And I do have a couple of follow-ups for you later, so you can get ready for it. I want to go to Courtney, to you. We introduced Blitz the Barriers, right? A really important initiative around Black patients, veterans, going into rural communities around prostate cancer detection. So maybe you can give us some insight into this really important initiative and some of the work that you're doing to really help the screening of these prostate cancer patients throughout the U.S.
Sure, thanks. And, before I just say that, I just want to say to this room, as someone who is about 6 months shy of her 20-year cancerversary from breast cancer, which was 6 years after my, thank you, which was also 6 years after my brother had colon cancer at 23, after my uncle had melanoma at 24, with no current genetic component. The work we do pan-tumor together is especially important because every data point is a person and a family. And so I joined Zero in part pretty much to sort of bring the fire of breast cancer to prostate cancer. My dad is living with prostate cancer. And quite honestly, if you look at these sort of screening rates, first of all, prostate cancer isn't even on the chart. And one of the unique things that happen in breast cancer is the importance of advocacy and the importance of working in community. So what we did at Zero was we looked and we said, okay, we were known primarily as a great support organization, as an advocacy organization, but it was really time for us to think of ourselves as a public health organization. And because of that, we started to look at what were things that we could control to not just improve quality of life and support, but how could we save lives? And so for that, we had 3 key impacts that we drive everything to now at Zero. And that is, one, to reduce late-stage diagnoses for various reasons, which I'm sure we might get into. It used to be that 1 in 10 men who are diagnosed with prostate cancer were diagnosed with advanced disease. That number is now close to 1 in 4. And that is directly linked to some things that have happened in the last 15 years. So that means at Zero, we had to be much more involved in the screening game. We had to be much more involved in the early part of the continuum. That is pretty much what we'd seen in our breast cancer friends, in our diabetes friends, cardiovascular disease. We could not wait until people got diagnosed to get involved. We also want to make sure, as part of our DNA, that people are living longer and better. And for that, that means guideline concordant care. So all across the entire spectrum, how do we at Zero drive systemic change to drive guideline concordant care? And we know we're a smallish national nonprofit, but we know that we have to drive data and research that can show that not only is it good for patients, but it's good for business, it's good for doctors, and we can show that we can be a great partner in that. And we believe all of that will drive down mortality. So what that led us to do is, in February, and disclosure, with our friends at Novartis as our founding lead partner, we launched the largest patient-focused and community-focused prostate cancer initiative in U.S. history, which is a $20 million commitment over the next 3 years to be doing work in community. And that is pilot work, which, quite honestly, isn't that innovative if you have been working in any other disease state. But in prostate cancer, what was happening is that things were happening a little bit here, a little bit there, but there was no national infrastructure to help that information and data rise to the surface. Because if my first mentor in patient advocacy ever told me, all healthcare is local. So if we are not working in community, all of the diagnostic tests and the treatments don't matter if there is still stigma and barriers to that screening. And prostate cancer in particular not only has some significant stigma around its treatment and care. Ask any man who has Googled prostate cancer and comes up with the phrase metastatic castrate-resistant prostate cancer and wonder what that means for his care. But there is significant disinformation around how screening is done, especially in the Black and rural communities. If they talk about this more than a blood test, then you know that the disinformation is still there. And so with that, we launched an initiative over the next few years to be putting zero staff, zero community health workers. We have 4 different kinds of patient navigation because we know patient navigation works. But by the way, the work that it does is primarily very expensive and very resource driven. So how can we use volunteers? How can we use survivors? How can we use care partners and caregivers to help drive navigation? And so we're really proud of the work that we're launching. It also means we have a measurement and evaluation team for the first time at Zero, because all of this won't matter if we can't disseminate it and show why it's good. But what we hope is that this $20 million investment in the next 3 years drives the data and the information that gets us the next 100. And for all of you who are sitting here with your logos on the wall who are worried that we're going to come to you for that, the answer is no, we're not. We're going to use that the first 3 years to drive the investment from others who will pay attention, because for a cancer that impacts almost as many people as breast cancer, and almost as many people die from prostate cancer as breast cancer, the disparity in how we treat prostate cancer is appalling and unacceptable. And as I was a fundraiser for a long time, right? And some people say no money, no mission. And at Zero, we really believe that big mission will get the money. And so we have to think bigger to make that happen.
All right. You can see why I like working with Courtney, like the passion, I love it. No, it's you know, you said a lot of great things, but in particular, I've thought about this myself. I mean, breast cancer is a terrible disease, but the work that's being done in breast cancer, the work that has been done in breast cancer is amazing from an advocacy perspective. And if we can get halfway there with prostate, just halfway, it would be such a big win, and we would extend and save so many lives as it relates to prostate cancer. So thank you for sharing that insight. I'll go to Dr. Nassal. I'll go to you next as well. We know that there is a significant number. We were hearing earlier about Medicare, Medicaid, but there's a lot of people who are uninsured and underinsured, and especially in a lot of the marginalized communities. They continue to see lower rates of screening in those communities, right? Your zip code sometimes plays a big role in if you're going to get screened or not. And getting access to health services can be challenging. So what I'd like to ask for you as a physician, from your perspective, if you can tell us in particular, what has to be done in this type of setting in those underserved communities, and what are you doing in these underserved communities to help improve these screening cancer rates, which obviously at the end of it is going to have a significant impact on outcomes?
Absolutely, and thank you so much again. I'm here representing the American Academy of Family Physicians. We are the largest primary care organization in the United States, and family physicians deliver comprehensive primary care that includes cancer screening, coordination of cancer-related services, follow-up survivorship care, and support to family members and communities for those who have experienced cancer in 95% of the counties in our country. The AFP has a long history of focusing on evidence-based medicine and making sure we're embracing innovation in the care and screening, particularly of those patients that you heard are really important to me. So as a family physician, I see patients of all ages, all genders. I take care of pregnant people. I do procedures. I see people living with HIV, complex chronic illnesses. My clinic where I work is in the South Bronx. I'm one stop away from Yankee Stadium on the 4 train. And the county that I work in and provide care in is one of the most under-resourced in our country, and in fact has the worst health outcomes in all of New York State. In my organization, you heard I work as Vice President for Innovation and Optimization, and I'm the Chief Medical Information Officer, so I have a unique perspective on all of our clinics throughout the Mid-Hudson, Bronx, Manhattan, and Brooklyn, rural to urban care. And we're a federally qualified health center, and for those of you guys who don't know, that means we see everyone regardless of their ability to pay. In addition, we train family medicine residents and nurse practitioner residents, and besides the care that I provide at my clinic in the South Bronx, where about almost 90% of my patients are on Medicaid, I also have run a free clinic in that same community for the last 25 years, of which all of our patients are fully uninsured and usually uninsurable. So what does that mean? That means when I'm at a conference like this, I know that many of the innovations that I'll hear about and you'll hear about on this panel and others are not available to the patients I serve. The populations I serve are disproportionately represented with lower screening opportunities, less successful screening, and worse cancer outcomes due to those things you've heard, and a higher burden of non-medical social needs that interfere with screening and treatment opportunities, a medical system structured to provide greater access to wealthy and those concentrated in urban centers, a medical establishment that has historically been and continues to be non-trustworthy partners to many communities and to my patients, and systemic racism in the practice of medicine and the structure of our healthcare system. So while I'll mention 3 important innovative approaches to engaging, supporting, and executing screenings in these under-resourced communities, I want to first speak about the core of improved health outcomes for my community, primary care. Primary care clinicians are the only clinicians that improve life expectancy and reduce disparities. Research shows that adding primary care physicians to a community results in measurable increases in lifespan and more equitable health outcomes. So at the core of each of these innovations and interventions, a continuous relationship with a primary care clinician, and I recommend a family physician. So 3 amazing endeavors we've been able to do because of being a federally qualified health center, because of being dynamic and versatile in seeking grants and support and opportunities from sponsors like yourself, from private entities, and from the federal government in the past when those resources were available. One of those core pieces was community partners. And we had the longest running REACH program, so for some of you may be familiar, the Racial and Ethnic Approaches to Health, which was a CDC-funded collaboration with faith-based organizations. So we were in over 80 faith-based organizations. That's where people are at. That's where the people who aren't accessing screening, that's where poor people who are trying to survive under rough circumstances are. And that long-term relationship and collaboration has been an incredible ability to connect people to care and to screening. And along those lines, you can imagine that the individuals in that community, so our second intervention, peer educators. So our organization has focused on facilitating and developing community healthcare workers and care navigators. We don't just hire people who fill those roles. We look for people who would not qualify, who have lived experiences, who are in the community, and created a curriculum that made it possible where we paid individuals to be trained who would have never been hired by most prominent healthcare organizations, but are the best representative of screening, surviving, of really speaking to that community. So that work and that funding of that work, immeasurably important and successful. And finally, and all of these I can speak to more with more questions later, but finally, for marginalized communities, for under-resourced communities, patients are like, I can't miss one day of work. I will not be able to pay my rent. My kid won't have food. I can't get their asthma medicine if I miss that one day. It's really hard for us to imagine that level of impoverishment. That's my everyday. Those are my patients every day who are sacrificing to be seen in the office with me. So we organized One Stop Shop, which is a single day where everyone who presents can get all of their cancer needs either physically addressed, if it's something on their body that can be evaluated that day, or to have any further screening arranged, set up, organized, and facilitated in the manner that is the most successful for them. So instead of like one day going and getting a pap smear, and one day going and getting a mammogram, and one day going and doing a FIT or FIT DNA test, that actually all of those resources were brought into a single day within our clinic, and has been really successful, particularly for those individuals from under-resourced, marginalized communities who can't do all of those visits. So that's my little start. Thank you.
Dr. Nassal, thank you so much for sharing. It's interesting, just to be very transparent, because I almost stumbled. I wanted to call you an oncologist because I'm so used to working in this space with oncologists. But I think about the important, like the words you just shared, you are seeing people I like to call at ground zero, like right in the streets. I mean, South Bronx, I know that area, although I'm a Mets fan, not a Yankees fan. But it's critical to get to those communities, and it's really almost the first place that they get introduced to the healthcare system. And it's because of people like you that we get to sort of take it from that stage of diagnosing it early enough where they potentially have a chance, right? It's not stage 4 where they're being diagnosed, but being diagnosed early. So thank you so much for all your great work. Appreciate it. Okay, Tracy Lewis, coming to you now. Your work is to increase the uptake of colorectal cancer screenings, and specifically in South Carolina. I know you're doing some great work there with a focus on those areas with the lowest screening rates. And I think we've heard this word before around working with patient navigators, right? And you're doing some work. Can you talk about the role of patient navigators in the work that you're doing and the impact that they're having in the community? And we love to hear about the pluses and the minuses, right? What are some of the challenges that come across with it? Because a lot of times, having a navigator I know is a good thing, but it's not always an easy thing as well. So please share. Thank you.
Thank you so very much. I do want to take the opportunity to thank ACS CAN for this wonderful day, but also to thank them for the support that they have provided the Colorectal Cancer Prevention Network starting back in 2010. I am here today because of their advocacy efforts and help secure funding for our program at a state level. And thanks to their efforts, we have recurring funding from our state legislators. So I am here today because of the work of ACS CAN, and truly appreciate everything y'all do. So it is an exciting time in the world of patient navigation. Our program has been a trendsetter with patient navigation. We started patient navigation in 2010. To really, truly help uninsured, low-income individuals to get from referral to colonoscopy, because back in 2010, colonoscopy was really, truly the only screening option for colorectal cancer. And look where we are today in 2025. Right now, we have 5 different options for colorectal cancer screening, and listening today, we have several more that will be coming down the pike. So we'll look forward to seeing how that impacts screening completion and follow-up care. But in my role overseeing 11 navigators throughout the state of South Carolina, they are strategically located, so they do represent the community that they serve. Living and breathing in the community that you serve builds trust with the patients that you're talking with. So I think one of the critical pieces for patient navigation is being able to build trust with the patient, and also not only trust between the patient and the navigator, it also helps improve the trust of that patient within the medical community, which is very important today. It's always been important, but that is something that we see repeatedly since COVID, of a lot of our patients really not trusting within the system. So our navigators listen, they identify barriers, and they address as many of those barriers that can be addressed in order for the patient to be successful in completing their screening. So some of those barriers that we can address: transportation, Love Uber Health, gas cards, that helps with transportation. We can address low literacy. We can address language. We can address homelessness, working with resources to find housing for that patient if they need to prep and be able to get to their colonoscopy the next day. The one barrier we can't address is caregiver. It's having a caregiver to go with them for their colonoscopy. And you'll be surprised how many people do not have a caregiver that can go with them. They don't have a friend, a family member. A lot of these individuals live in silos and don't know their next door neighbor. So that is one of the hardest barriers to hear for my navigators. They start even saying, oh, what's the local church, do you go to a local church? Or I'll look at a local church and see if they'll take you. And a lot of patients in this situation are very private and do not want us asking a local community member to take them to their colonoscopy. So I think for us, that is one of the biggest barriers that we face within our program. But like I said, we've made a lot of advances in screening modality options for patients. So to address the time off work, the non-invasive tests are ideal for those patients so that they can get screened. And only if that result comes back positive, then there is the next step of completing a colonoscopy, and it gives them a reason to get that colonoscopy completed. One of the other critical pieces of our patient navigation program is the education. We've heard in the first panel talking about screening starts with education and understanding that if you're going to start with a non-invasive test, that there is a possibility of a second test that needs to be completed to determine why you had an abnormal result. We also have to reassure the patient that just because you have an abnormal result from a stool-based test, that does not mean you have cancer. Because in this population, they are so used to seeing people diagnosed with cancer die. And so in their mind, if they get a cancer diagnosis, they're going to die. So we start with the education of, this is a great test for you to complete. It allows you to get screened. If it comes back positive, it does not necessarily mean you have cancer. It could mean a lot of other things. It just means you have blood in your stool, and we got to find out the reasons why. So we lay the groundwork with our patients when we start screening with them with a non-invasive test that we will be following up with you if it comes back positive to continue your screening. We have a medical liaison that's part of our team, and when we have an abnormal result, my medical liaison calls that patient directly to provide them with their results, to talk to them about what that result means, address any of the fears that that patient may have at that point in time of hearing the results of you have a positive. And then my medical liaison does a warm transfer of that patient to their patient navigator to continue with the scheduling of the colonoscopy. In our program, our goal is to have all abnormal stool-based testings scheduled for their follow-up colonoscopy within 8 weeks. And most of the time, we're very successful in that. We, of course, have patients that are still very hesitant about going forward. So we re-educate, we connect other medical providers to them to address additional questions. Most of them have a fear of going to sleep, that they may not wake up, because anesthesia is dangerous in their mind. So we address those fears. And so I think, and then they have their colonoscopy, and when the results come back from that colonoscopy, we're there. My navigator's there finding out how their colonoscopy went. Is there any furtherment of care that is needed? If there is furtherment of care, my navigator works with that patient's medical home to coordinate scheduling of a surgical visit or straight to oncology. We make sure that that patient, if there is paperwork that needs to be completed in order for them to qualify for charity care at the local hospital, we're able to get that paperwork and help them fill that out, because we are dealing with individuals that are not so sure how to fill out paperwork. And sometimes their medical home will assist, and sometimes they will not. They'll just like, oh, thanks for letting me know that this patient has a need. And then that's where it stops. And so my navigator will carry that patient forward and make sure that they are scheduled for their follow-up care. Sometimes my navigator actually does a warm transfer to an oncology navigator. And those are, those are the good situations where we can just say, oh, here is so-and-so, and this is where they've been, here's their colonoscopy, here's their path, here's the recommendation. And then that oncology navigator takes over and makes sure that that patient completes their care. Last year we had 6 cancer cases, which is the most we've had in any given year since we've screened. All 6 of them were able to move forward with surgery and securing treatment, and 3 out of the 4 out of the 6 have completed their treatment. So we're very excited about that. Our patient navigators, at the end of the day, really, truly, they're the glue, right? They make it look simple. They remove all the barriers that the patient would face in regards to trying to figure out how to navigate our medical system. Our medical system is great, but until you have to navigate who I need to call to schedule an appointment, where do I need to go because I called this place for this appointment, but I actually have to go over here for the procedure. My navigator actually is the glue. They really remove all of the questions and the doubt from the patient and help them be able to move seamlessly through the process. And I want to say that besides ACS CAN's support for our funding and the way the state legislature write our funding, it's a private-public partnership. So it's not just our state funding that we receive. For every dollar the state gives us, we have to match dollar for dollar. So our GIs, our anesthesiologists, and pathologists all donate their professional fees for our program. And so that's how we match our state funding. And when you talk about innovation and how do we get uninsured individuals screened, it is through those networks of bringing all the providers to the table who have to provide that service to that patient. And in the years that I've worked with the Colorectal Cancer Prevention Network, most physicians are willing to give of their time. They're gracious. They want to give back. What gets in the way of them giving back? It's the administrative side of a hospital or the freestanding endoscopy center, because there is a bill at the end of the day, right? And there's time to be charged. So working out the cumbersome billing system for them not to bill our patients and send us an invoice for the services provided can take a lengthy time to get in place. We've worked with one hospital system that took over 4 years to get established. So the work isn't for the faint of heart. You got to be dedicated, and I think everybody on the stage has the passion and drive to make sure that whatever barrier that we face to provide the screening, we're going to knock those barriers down so that we can serve these patients and provide the resources that are much needed for this community that is underserved.
Thank you. Thank you, Tracy. Patient navigators are so important. And there was just one word I just honed in on in your comment, and it was the trust one. Like, nothing happens without that trust, whether it's just trusting that that navigator has their best interest, trusting to have the real conversation with them. And so thanks for all the work that you and your team are doing in South Carolina as well. All right, I'd like to throw out a question maybe for whoever would like to answer it. But the thing I was thinking about as I listened to each of you, in order for us to make progress, you got to come up with innovation. And I think there's a lot of good innovation that is coming to the forefront. But how do we make sure we get that innovation to everybody, regardless of your zip code, right? Regardless of your income status, regardless of where you live. So anyone, love to just hear some of your thoughts on that.
I'm happy to pitch in on that one. I'm sure we all have a lot of opinions. I want to speak a little bit to the trust. I really push physicians not to talk about patients trusting them, but how are we as physicians trustworthy partners? And I think that goes to how do we get both screenings in place that are new and innovative that I'm excited about, but no, my patients aren't going to have access to. And then how do we make them really valuable and worthwhile and something that the communities and patients trust as something that they should actually be doing? Clearly, we've all spoken about payment, but there's why we need to have these elaborate systems of donation in order to provision care. We should be negotiating with no one to be able to do evidence-based intervention. So those pieces that are in place of making sure we're showing the evidence behind our new interventions that we're seeing, and we're seeing that research being done here. And then really our obligation as both the companies developing these, engaging, incorporating the communities that we're going to do this in to show that we are in fact trustworthy partners and using those profits to invest in those communities that in fact we ultimately will profit from.
I would throw out that I learned a long time ago that people need a seat at the table, but a seat at the table is not enough, because if people don't feel like they're welcome at that table, it doesn't matter if you invited them a million times. So when we're working in community and we're trying to drive access, the importance of having patients and community not just invited to the table, but that the table is the right size for them, the right, is it comfortable for them? Is it that? And it's not just enough that they have a seat at the table, they have to be able to read the menu. And so I think it's our important thing that when we are working at how do we drive access, of course, I'm a patient advocacy organization, so I believe that it is through grassroots galvanization in conjunction with policy and payers and all of those things. But if you create a situation where people are too big to ignore, change happens. And then the third part about that is it is not just enough that they can read the menu. Did they help you create the menu? And so to me, one of the ways that helps solve a trust issue, but it also can help drive access is, are your communities, are your patients, are the people who have the most to lose, which is their lives, which is their families, which is their house, which is their jobs, are they driving this process, or are they an afterthought? And I think that's the one thing that, groups like this and ACS CAN does and lots of patient advocacy groups do. We have to do a better job of educating and empowering those people in communities to have the tools to feel like they can fight for what they need, and then give them the tools to be able to do that with a freedom that from repercussion, especially in this environment, that they can be a much more active partner. Because I can say all the things, I want from my, chair as a CEO, but we can drive access if we empower the communities to think differently about how they can be in the driver's seat and what are the tools we give them to do it.
I'll just briefly comment from the perspective of a novel screening test developer. Oftentimes when we're initially bringing a new technology to market, it's expensive. It requires a high degree of sophistication in terms of the equipment and the materials that are used. And our job is not done until we drive the innovation all the way through to lower cost solutions. And I think for those of us who work in this space, broad patient access is what motivates us, and there is a cost component to that has to be part of our design principles from the beginning.
I also like to add, we know physicians are very busy. They have very limited time with the patient. And Dorado talked about, most patients aren't recommended screening because the physician didn't have time to recommend it and talk about it. So this also impacts new technology and new screening modalities because, one, they don't even have time to talk about colonoscopy, let alone talk about other screening modalities. So looking at that clinic and who in that clinic can provide that education and knowledge about the screening modalities and really truly make an informed decision with that patient about which screening modality is the most appropriate for them based upon their circumstances, risk assessments. So I think we also need to look at our healthcare model, and putting it on the physician is not going to help us drive these changes. We have to really truly look at how we can change the model at a clinic so that the patient can get the information, ask their questions, and not feel like they're being pushed out the door. Because a lot of times patients have to process information before they have a question. And if your physician just said, oh, it's time for your colorectal cancer screening, here's your referral, that is not, it's not a good practice, and that's how we lose people in regards to screening compliance. So I think we also need to look at how we can use the clinic and the staff to their fullest level.
Thank you. Some really good insights that you've shared, each of you. So I'd like to ask one last question and then maybe get the audience ready for any questions that you may have as well. Listening, and Tracy, you talked about public-private partnerships, and it made me think about funding, right? And are we only relying on the federal government to help us in this space, or what are some of your thoughts on how do we do more with less? Or how do we find new partnerships? Like what's going on in your space to help sort of improve this increase in cancer screenings in areas that are not traditionally done? And I'll throw it out to each of you.
Well, I can start, this is obviously from the test developer perspective, and as a private company, we're funded by venture capital primarily. I'll share what I found to be sort of a shocking statistic. I keep a tally of the private investment that's gone into screening test development. It's a little over $5.5 billion that's been invested in this space over the last 5 years or so in a variety of companies. About half of that have gone into companies seeking to develop additional screening tests for which we already have screening solutions, so lung, colorectal, et cetera. About the other half of it has gone into tests that are seeking to develop these multi-cancer early detection modalities. And the justification for that is really this pending legislation as a pathway to get those tests paid for. About 1% has gone into the development of tests in new categories of cancer. I shared the example for us with ovarian, but wouldn't we love to see investment pouring into pancreatic cancer screening, to liver cancer screening? And so there is a systematic disincentive to investment in screening for new categories of cancer that I think we must address if we're going to move the needle in some of these really, really important unmet clinical needs. And that, I think, can come perhaps through the federal government, but I think it can come through industry, through venture capital, and through partnerships between diagnostic companies like ours and companies that work on the treatment side. I think those are increasingly going to be the types of partnerships that we see to move the needle in these new categories.
Thank you.
In thinking about how we fund the care that we provide, particularly at the free clinic that I've worked at for the last 25 years, whenever I speak about it, I started there as a first-year med student. It's why I chose to go to the med school I went to. It had been founded the year I was applying to med school. It was the first student-run free clinic in New York State. And I was so proud to get to serve the community there. And I'm so sad we still need it 25 years later. And we've had multiple amazing private partners who have donated to both innovate at the clinic, to sustain the clinic. Private donors to organizations like ours and other health organizations like to see new things happening that they're funding. So something that continues to have a need, well, where does that obligation fall? And I'm really lucky to be in New York State. We do some of the best state support for services that go beyond what is available in routine Medicaid. I pay really high taxes, and I am so glad. I'm so glad every time I see a patient living with HIV who's undocumented that I can see in my clinic. I'm so glad every time I see an immigrant patient who found out they're pregnant and want to be, and they're there in my office and I can initiate prenatal care immediately or provide them with termination services if they do not want to continue that pregnancy. These are all things that are made available by my heavy tax dollars, and I'm proud to pay them, and I hope that all of us can look at that perspective. When there's sustained need, is that really the place where donations and dollars should come from? Or when there's sustained need, what are we obligated to really be providing our communities?
Okay, I'm going to go to questions for the sake of time. I see we have one over here.
Yeah, and I know we're running time, but John, you just said something I'd like for you to expand on a little bit more in the context of this can't be the status quo anymore, right? You talked about broad access needing to be considered in your product design, I think is what you said, or maybe a product come to market. Can you just tell us a little bit more about that, and how can we help, as patient advocates, sort of help companies really think differently about maybe they're marginal changes, maybe they're really important changes, but getting into that process sooner. So you just talk a little bit about what you meant when you said that.
Yeah, there's two elements to it, I think. The first is I'm at the beginning of a development program. Let's just say, hypothetically, I want to develop a test for screening for pancreatic cancer. I think we can agree that's an enormous unmet need. I know from the very beginning that this is not a test that is currently a benefit category in Medicare, so I know I'm going to have to fight the battle to get coverage. And so I think to myself, if I'm going to bring this test to the market, knowing that it may well be many years before I get coverage through insurance, I darn well better bring that test to market at a price point that at least a fraction of the population can pay out of pocket. So here we're talking about, tens to hundreds of dollars, not thousands of dollars to get a screening test done. And certainly recognizing that still excludes really important sections of the population. It's a place to begin as we develop the clinical utility data that ultimately serves to secure broader reimbursement, broader coverage. So I think that the designing with the end in mind is an essential responsibility for those of us who are test developers and bringing these tests to market. And that means that the choices that we make really early in this process about the types of technologies that we're going to use, the components that we build into the assay, they really matter. And so I think the responsibility that's incumbent in us as sort of a sacred trust is that we are doing this work from the very beginning with broad patient access in the front of our minds.
And I can ask, I would add too, how do advocates get more involved? That would be sort of my challenge to anybody who's in industry in the room, is to get patient advocacy organizations who can get you great advocates involved in your process much earlier. If I had a nickel for every time in my 20 years somebody has come to us and said, it's taking us too long to get to market because it's taking us too long to get data, and I look and I go, because no one is going, your trial design was not patient-centric, you don't have right partnerships to help you recruit, to help do these things. We are trying to be the Band-Aid to getting you data after you didn't involve us on the front end. Patient advocacy organizations, and especially well-trained advocates, will make your job faster, easier, cheaper. And all too often, patient advocacy organizations are brought in later, and this is across all the things. If I had a nickel for every time somebody's like, oh, I have a grant that I have to submit, and we need a patient advocate. By the way, can you just give us your CV? And I say, well, what is the design? What's the science? Oh, you don't need to worry about that. And on the patient advocacy side, it's our job to help train them. It's my greatest joy when people ask me, oh, you must have a science background. And I say, no, I was a theater major. Instead, I am the product of hours and hours of investment that advocacy organizations put in me to teach me to be ready to be a better partner. So that, I think it's beholden on both of our ends to work with each other earlier in the process, because it'll make the process be that much faster.
Okay, now I'm in between you and lunch. So I'm going to end this panel. I will say before, this panel was about what's new, innovation and new approaches. And I think what we heard is there is a lot of new, right? A lot of new approaches, a lot of new innovation. But so what if it doesn't get to everyone, right? And I think that's the work we all have to do, is do our part to make sure we're getting these new innovations to everyone. But sometimes it's about what's old as well, building trust, right? That's not new, but building trust. And there was something that was said that I loved, was having, I think you might have said it in terms of looking at Dr. Nsala. I wrote a note here, trustworthy partners. I think that was it, right? How do you build, how are we becoming trustworthy partners? And I think that's such an important point. So with that, I'd like to say a big thank you to Courtney, to Tracy, to Dr. Mattoon, Dr. Nusal. Thank you guys for your insights and sharing. And more important than your insights and sharing, just the work that you do every day. Thank you.
Thank you. Now it's lunchtime.
Okay, I was supposed to give a lunch thing. There's food in the back. Come back within 30 minutes. We are starting the next session, so mingle a little bit, bring your food in, and thanks, everybody.
We got to take a picture. Sarah, come back. We got to take a picture.
Welcome back. I hope everyone had a chance to enjoy some lunch. Please feel free to continue eating during this session. So we're going to switch gears slightly and move from a formal panel format to more of a fireside chat. And the topic is risk of cancer in younger people, people in their 20s and 30s and 40s. We've heard all of our panelists this morning talk about screening and increases in cancer in these populations. So please help me welcome to the stage Dr. Arif Kamal and Dr. Ramona Burris. So Dr. Kamal is the inaugural Chief Patient Officer for ACS. In his role, he oversees the organization's support network, patient navigation services, education programs, patient and caregiver lodging and transportation, our 24/7 call center, and a host of other programs. He is also, in his spare time, a practicing oncologist and palliative care physician in North Carolina, an associate professor of medicine and population health at Duke University School of Medicine. Dr. Burris is a transformative leader in healthcare, patient engagement, and health equity, with a career spanning over 15 years in healthcare administration. She is deeply committed to championing women's health issues, advancing health equity, and delivering quality preventive services. Currently, she serves as the Chief Development Officer at Onyx Medical Wellness, where she leads efforts to bridge healthcare access gaps, foster strategic partnerships, and drive community-based health initiatives that prioritize integrative, patient-centered care. Welcome to both of you.
Thank you.
Thank you. So, as was mentioned, this is going to be an informal chat between Ramon and myself, and we both agreed while we have formal terminal degrees and titles. I'm Arif and she's Ramona, and we are fast friends that connected around this concept of this worrisome trend of people being younger diagnosed with cancer. And I think it really goes without saying that the experience of cancer is different based on the stage of life that a person is in. And if we think about the ecosystem of cancer care, it was largely built around the concept of people who are a little bit later in life being diagnosed, and that's all the things that have been supportive in their approach have been focused on that part. And the reason I bring that up is because we've thought about the concept of financial resiliency, relational resiliency, emotional resiliency, oftentimes in the construct of a person who may be retired with a large, maybe financial nest egg to pull from, maybe a large social network to pull from, and their responsibilities day to day are different, not necessarily less, but I can tell you as a parent myself, I know that in my stage of life, the things that make me stressed or busy in an average day are going to be different, I think, than 30 years from now. So I'm joined by Ramona because we're talking about this issue of greater numbers of people being diagnosed at earlier stages of life. And I think what you're going to hear from us talk not only about sort of the biological challenges of that, which are many and really underlie the reason why continued research funding is so paramount to understand really the why of that's happening, particularly as we see some cancers not only show up earlier, but also show up in a person who may not have a compelling family history. And that in and of itself is a unique challenge because we've historically thought about cancer at earlier ages being generally tied to a compelling family history, and thus we might have predicted that were to happen, and thus it's really sort of an age shift that we might have expected. But as a practicing oncologist, I can tell you 15 years ago when I first started practicing, it was pretty unusual in my state of North Carolina to see folks in their 30s and 40s being diagnosed with cancer. Unfortunately now, that's just not the case. So much so that we used to have, multi-D evaluations and conversations as clinicians about like, oh my gosh, what did you say again? Oh yeah, I have a 35-year-old. And people would pause and go, oh, really? Like, you sure? Like, what's the story there? And you kind of put it together. Now I can tell you when we have these conversations as a multi-D team, we don't even pause anymore. We just say, this is a 35-year-old woman with blah, 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 triple negative breast cancer, blah, blah, and we just go on with the rest of the case. And it's reflecting the fact that we epidemiologically, but also at the 3-foot level with patients are seeing this as being quite normal, and in of that's disturbing. So Ramona, as we've gotten to know each other, you have a very compelling personal story that reflects some of these challenges of being diagnosed at a different stage of life, at an earlier stage of life, and you've been very open with that. So I wonder if you'd share with this group sort of your experiences and the challenges you faced.
Yeah, definitely. Thank you, everyone, for being a part of this event today. So yes, I am currently 45 years old, so I'm at that middle age of life, but I was initially diagnosed with stage 2 breast cancer at the age of 34 with no known risk factors, no family history, nothing that would point to me being at risk or let alone being diagnosed for breast cancer. And I found my lump while I was taking a shower one day. I never had the privilege and honor of having big boobs. I tell people that all the time. And I'm a mother of 3 kids, and they were much younger, but after breastfeeding them and, kind of losing some of that elasticity and that firmness of my breast, it wasn't that hard to feel a lump. And I live in Chicago. I'm a pharmacist by training. I've been a clinician. I've been a researcher. And all of that really influenced my patient journey, but I had to force it to influence my patient journey because this is what happened. I felt the lump, ignored it, right? So it's important that when we're talking about patients and talking about community engagement, that we recognize that there are so many behavioral underpinnings that drive how a person has symptoms and how they enter into care, how they navigate care, how they stay in care. So I should have known better when I felt a lump, but I let it sit there for about a month or two. And then I called my primary care physician, who I love, who I still have her as a doctor today. And she knew at that same time of me complaining about this lump in my breast that I had just seen her maybe 4 months prior for my annual, and there was nothing identified during that engagement. And she also knew that I was going through a life change of getting a divorce. And she's like, Ramona, you know, I just saw you. Let's just, maybe it's your menstrual cycle. Let's just wait and see. I called her again 2 weeks later because it started to get bigger. And again, I got dismissed. Ramona, you know, let's just, it's not a priority. I don't want to disrupt things for you. You have a lot going on, so let's just wait. And then 2 more weeks, it started getting really painful. At the time, I was still a pharmacist at Walgreens, so I was a pill counter. And the lump was on my left side, and I'm left-handed, so it was impeding with my ability to count pills and type. So that third phone call, she finally listened and got me in to see a provider within her practice because she didn't have an appointment available. And at that appointment, the physician felt the same lump that I had been feeling for probably like 3 months at that point. And her words to me were, because you have Blue Cross insurance, we're going to send you for a mammogram. That may sound triggering, but think back, this is like 2013, so guidelines were a little bit different. But, you know, for her to explicitly state that she was confident that putting a referral in because of my insurance type would allow me to get that mammogram screening was, you know, eye-opening. And you know, again, policy has driven change, so we're seeing some change around that. But if I had been Ramona with Medicaid or Ramona with some other insurance, would I have been sent for that mammogram to thus get diagnosed with breast cancer? My story could be different. I'll pause there because there's a whole bunch of crap after that.
Yeah. Ramona, let's talk about the crap, actually, because let's talk about it. So for those who, you know, may not be close to a story like that, and again, I started by saying, like, it's different, right? You were talking about in your 30s. You got 3 kids, undergoing a life change. You're a working professional. So, you know, if there were, I don't know, if there, you know, policymakers in the room and decision makers in the room who said, gosh darn it, this is different at 34 than at 64. It's not better, it's not worse, it's just different. Can you describe how it's different?
Yeah, so as someone who's type A driven, I suffer from the superwoman complex. And as women, so oftentimes we put others' priorities before ourselves, especially if you have a family, but that can extend to beyond the nuclear family, right? So that's why I ignored it for so long. But then I was also career driven. So taking time off of work, even though I was an executive at the time at Walgreens, it would impede how I was showing up as a leader. So I delayed and I delayed until, you know, the lump was just there and so uncomfortable that I went to go get treated for it. So who knows what opportunity or window I missed by potentially have been cured, right, after chemo, after radiation, to have prevented. This is some of the guilt that I carry now, being a metastatic cancer patient. Like, did I wait too long? Is that why I'm still, you know, with cancer to this day? So I think it's those other identities and responsibilities that we have as young folks, as women, that, you know, really do impede. And that's why I say the behavioral piece, you know, telling folks who are living with symptoms, whether they've been diagnosed or not, that they are worthy of the time off. They are worthy of whatever it takes for them to get engaged in care.
Yeah, it's really insightful. So, you know, again, as I was mentioning, the system was set up when we thought a lot about, you know, this is a Medicare age issue. Cancer is a Medicare age issue. Now what you're talking about is really, it is an employee age issue and an employer issue. So, you know, you don't have to speak about to your employer itself, but if you were to advise employers and employer-based insurances to think about programs and services and coverage that would be tuned to the working age population, what would you emphasize they should include?
Okay, so I've already acknowledged who the employer was, but you know what? It is what it is. So having better benefits packages. So with my diagnostic journey, I went through the typical biopsy, to get the official diagnosis. The cancer was in my left breast. There were a couple of lumps. I met with the surgeon to, determine what was going to be my care treatment from that perspective, but then also what my chemotherapy treatment was going to be as well. The influence of celebrities. At the same time, Angelina Jolie was going through her prophylactic double mastectomy, and I think she had an oophorectomy or something. And seeing her on Good Morning America as I was going through my own decisions, I was like, okay, maybe I will select the double mastectomy option for myself, because the cancer was only in the left breast, but the surgeon was like, you're likely to have a recurrence in the other. Boom, okay, let's take off both of these. Let's give me some new boobs, right? Because I think I determined at that time I wasn't gonna die, so I'm like, let me get some new boobs, because I'm out here as a divorced woman, I gotta make myself marketable. But in that same conversation around the surgery and the selecting a double mastectomy, I had to fight for my nipple. So the tumor on the left side was close to the nipple that, okay, yeah, take it off, draw me in a new one, that's what they did. But then the right breast, where there was no evidence of cancer, they wanted to take that nipple too. And I'm like, no, can I keep my nipple? Like, identity. So, Dr. Kumar, I don't even know what the question was, but, but my nipples are important, right? But okay, the employer piece, that's what it was, the employer piece. Okay. So at the time of all this, it was like maybe December of the calendar year, and my employer at the time, we would renew our benefits that January of every calendar year. And unfortunately, that January, my employer switched to having a format of giving you all your sick days and all your vacation days blanketly at the beginning of the year, and they moved to PTO accrual. And by the time I had gone through all the diagnostic appointments and blah, blah, blah for that former year, I had tapped out of any carryover. So divorce, or going through a divorce, 3 kids in private school, trying to live my best life to show my ex-husband, like, hey, I can be bad without you, right? I was thinking about the finances, and so trying to schedule the surgery for the double mastectomy, my doctor and I had decided on February, but then when I started looking at the money, because of my benefits changed, because before you can get short-term disability, you have to tap out your sick days and your so-and-so, but I had no reserve of sick days. So I remember going to the corporate office of my employer, begging to be grandfathered into the former model of our benefits, and I was told no twice. And if you could think about how humbling it is to tell your employer, look, I'm stretched financially and I need your help, right? The humbleness of that, but then to even get rejected was very harsh. So what wound up happening is I kept the February surgery appointment, but I experienced financial ruin to the point that bills were behind, a car got repoed, and I actually went back to work sooner than I probably should have, because I was a sole breadwinner and I had to keep my kids' house. I had to pull them out of I pulled them out of parochial school, they moved into public school. So the impact of my diagnosis on the family was just, intense. Yeah.
Ramona, I think we all appreciate your transparency and vulnerability in sharing that. I think when we talk about the concept of financial toxicity, we might implicitly picture not an executive at a Fortune 20 company. And yet, you're sharing that exact story. So, to this issue of financial toxicities, right, we're seeing more sort of cost sharing.
Yes.
That's happening. And I think a sense of this tension between, innovation comes at a price.
Yes.
Don't people want innovation, and shouldn't we just pay the price? So you've got a lived experience. What do you say to that?
We should. So I am currently, I'm an unemployed pharmaceutical executive. And for the past few years, I've been working in drug development and really clinical trial design. And especially when it comes to our oncology studies, we have created models at whatever company you Google that I worked at, that we look at offering participants in the study standard of care in addition to whatever, curative things. So if you're on a hypertension drug, if you're on a high cholesterol drug, let's make sure we fold that into what you can get while you're in our studies because you are a whole person. So guess what? Now that I'm unemployed, and I've been unemployed for so long that my subsidized COBRA just expired, as a metastatic breast cancer patient, I was scheduled with my hospital to have a bronchoscopy because I have a suspicious lump or something in my lungs. My hospital called me to say, hey, your insurance is not working, which, you know, COBRA is funny. Before I could even respond to say COBRA is back up and running, it was just a so-and-so, so-and-so, the appointment got dropped from my MyChart, right? So I'm like, back to, I know this conversation is about young age or persons who are diagnosed at a young age, but this financial toxicity, it shows up even still today. And so I'm working with another pharmaceutical company to get in their clinical trial so that I can help kind of maintain, again, my full care while being, having my cancer diagnosis managed. So we need policy to hold everyone accountable. I feel like so much conversation, especially now with what's happening in legislation, there's so much ill put towards pharmaceutical companies when it's really a shared responsibility of how do we keep medications accessible, how do we keep innovation accessible. It goes to the payers, it goes to the institutions that are delivering the care. There's a shared responsibility, and I think that we can solve for these toxicities that patients are facing to remove them, because we do know that that's a known barrier to care, engaging in care, but also, you know, retaining our patients in care.
I think we're learning more about the effects of social isolation and loneliness, particularly in younger populations, but also if you guys look at the data, seniors have this issue too. You know, I mean, it is in and of itself an epidemic, which the previous Surgeon General highlighted. I think one of the best studies in this space actually was done by ACS CAN in their Survivor View survey of nearly 1,800 respondents looking at this issue. For those who haven't read it, I'll TLDR it for you. So essentially it says that loneliness and social isolation go up during a cancer journey. And in fact, most, I think about 60% or so from the survey, responded that they were more isolated after their diagnosis and as they went through their treatment than before. Which, when I share that with others, you know, sometimes I get a look of surprise, because there is this, what I would call, and what I've talked about as sort of this myth, I've called it the too many lasagnas myth.
Yes.
Right, and the too many lasagnas myth, which I hear sometimes from patients, is this idea that, like, someone gets diagnosed with cancer, their entire community rallies, and there's all these lasagnas that show up, right? But I think what we've learned is, one, to have too many lasagnas show up on your front porch is, one, probably an area of privilege, actually in and of itself, reflects something about who you are and where you might be. But also that, you know, somewhere along the way, cancer care for many people has become a chronic illness. Yeah. And just like everything else, you know, the attention span of the average American has gotten really short, right? Yeah. And I think fundamentally the attention span around empathy and compassion, and this is not a judgment of people, I think it's just a reflection, has also gotten shorter at the same time that for many people their cancer journey has gotten longer.
Yes.
And so while the lasagnas may show up for, like, my patients that I take care of in the first couple of weeks, maybe months, but for people who are going through this for years, I think the lasagnas start to disappear. The other challenge is that I don't know that as members of society we were ever actually taught how to communicate with others and to check in with others who are going through a difficult thing. And as a palliative care doc, this is what I do, this is what I teach to others, is how to connect. We've got some folks even within the ACS family who are going through some difficult times right now, and you know, I sent a text this morning to one of them to say, hey, was just thinking about you today. And that's my approach. I'm not sure it's the right approach or the textbook approach, but it is my approach to being able to check in with someone without requiring them having to respond back to you. Because there is a burden where you're constantly peppering someone else with questions that in and of itself the communication could get a little burdensome. But I do think in that my simple way, it says, I'm thinking about you. If you don't respond, that's okay. If you do, you could respond with something that's on your mind. So Ramona, I wonder, for you, you mentioned you were going through a divorce, you've got children. I imagine a lot of your relationships were work-related, have been work-related. Can you talk a little bit about those challenges as you've gone through your journey?
Yeah, there's definitely this, you know, isolation that occurs when you feel like no one else is going through what you're going through. You know, being a cancer patient, having survived cancer, having metastatic disease, has put me into a space where now I have heart failure, and now I have all these other things. And when you see me, you don't see it, right? But it's a reality for me. And some days I may not have the physical wherewithal to be present. Some days I may be depressed, because I'll tell you now, if this is 12 years from my original diagnosis and maybe 8 years of that being metastatic disease, I now have survivor's remorse, because there are persons who got diagnosed after me or before me, had more aggressive, less aggressive, what have you, and some of them are not here with us today. And so that's just the reality and the complexity of self-identity. And let's not even talk about like the sexual identity. I was telling Dr. Kamal that, even though I fought for the nipple on this breast, I still have body image issues where my kids who are now college age, I was at one of their houses a couple of weeks ago, and I was taking a shower, and she recognized that I was taking a shower in the dark. And she's like, "You're still showering in the dark?" And I'm like, "Oh yeah, like I still can't look at myself full frontal." So all this that a person holds in, it shows up in how you manage relationships, whether they're professional relationships, personal relationships. I was even talking to a cancer survivor of head and neck cancer, and one of my tumors is in my jaw. And we talked about, yes, radiation has saved us, we're still here, but radiation has damaged our teeth. And I'm like, you know what? I was just at the emergency room for something, and I saw on my chart, poor dentition, blah, 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 blah. And I'm like, butthole, if you don't just look at my chart and recognize that I'm not trying to walk around with a yuck mouth, but this is a consequence of survivorship, of having, so things like that, it really does impede how a person may want to be active or be in communications with their loved ones or with their professional peers, that we have to, keep at the forefront. And so thank you for recognizing that. Just reaching out, just saying hey without expecting something in return, that's the humanistic element that I want us as advocates, as healthcare professionals, clinicians, researchers to keep in mind, that our patients are people. And 20% of them is clinical, but that other 80%, that's where we can show up and do better and really keep this in the back of mind.
That's great. I think maybe we're both evangelizing for everyone who's listening. If you've got a phone, I think it's a good moment to remember, right, that to not be going through a serious thing also in of itself is a moment of privilege as well, right? Because what you're talking about is happenstance, right? You are in a different journey than I am, but there's not a rational reason for that either of us would understand anyway. So. You spoke about long-term effects, and I want to talk about that for a second. As a breast oncologist, I can tell you that the left-sided breast cancers are a little bit more tricky because right behind the breast on the left side of the body is what? The heart, right? And so when radiation's done to the axilla or to the supraclavicular area on the left side, it is a little bit more challenging. So, particularly for people who are younger, this concept of late-term effects or long-term effects is a little bit more salient. And I think as oncologists, we don't necessarily emphasize that as much because everything is like a 4% risk of heart failure, 1% risk of secondary cancers. And I would say that probably in our own practice, we kind of go, yeah, but this person's 70, so what are the chances we're going to get there? But this is more salient to you. So can you talk a little bit about what went well in terms of people addressing that, counseling you, how others have leaned into that or not, in terms of the whole health ecosystem sort of understanding what they should be paying attention to?
Yeah, so I don't think my journey was a good example of anything that goes well. And again, I come from a place of privilege. And so my story is not unique. I hear specifically for breast cancer, women who look like me presenting, even though in my inner body I'm a white man, but you see a black woman. That they had similar experiences, right? So to that, I say I use everything that went wrong in my narrative to promote something better in whatever space I'm taking. So whether it's from a drug development side, from a clinician side, from a sharing information and resources with the community. We have to meet people where they are. We have to recognize the whole of them, but especially for young women who are getting diagnosed at a way younger than 34. I think the youngest I've had today is 16. who have more aggressive cancers, we have to think about the survivorship piece, because we are living. Cancer doesn't have to be a death sentence, but let's talk more about the reproductive piece. I did not have that offered to me. Maybe 34, they said, oh, she got 3 kids, she's divorced, she ain't gonna have no more. But I'm like, whatever, my next marriage, I need that anchor baby. But I really make sure that when I'm doing whatever hat that I'm wearing, whatever work that I'm doing, that we integrate those resources to talk about, the behavioral health piece, talk about the reproductive care, because all of those were gaps in my own personal narrative that I want to make sure, as long as I'm here on this earth, that I am filling the void for others who are going through a similar journey, so that they don't have some of those gaps that I experienced.
Yeah. You brought up fertility preservation. There was a study in JAMA just a couple months ago surveying hundreds of patients who are of reproductive age, both men and women, asking whether they could recall. Now, we work in teams, right? You probably met a lot of people through your journey. So the question was really simple. Could you recall during your cancer journey someone asking you about your preferences for fertility preservation? Maybe not surprisingly, what the study showed was only half of people recalled that anyone had asked them about it, let alone their oncologist. So anyone had asked them about it. We did, at ACS, we did something a couple months ago. We launched a fund to help people who are between the ages of 18 and 39, and actually the largest place the fund went to was around fertility preservation itself, because it is an ongoing cost, right? It's not a one-time cost. We were actually pretty humbled by how quickly the funds went. And for those of you who know the space, you wouldn't be surprised that that's what happened. So I wondered, that's probably one example of a missed opportunity, meaning when we're talking to people, asking them a question, trying to address something, because the challenge is with fertility preservation, right? If I give you a cycle of chemotherapy, my ability to then either harvest your eggs or your sperm is much different, right? So once that horse is out of the barn, it's very different to pull it back in. Are there other things you wish people had asked you about, inquired about, was curious about in terms of your life in your 30s that they didn't and should have?
Yeah, menopause is real, right? So we're seeing all this fervor. Oprah talks about menopause and, ABC special, blah, blah, blah. But for someone who's going through chemotherapy, and many of the regimens put you in an induced menopause, whether you're breast cancer or other cancer, I wish that had been shared. Because as someone who's been on tamoxifen off and on for years, I know as a pharmacist, my drug adherence is poor because that tamoxifen makes me feel like crap. Chemo brain is real, right? So we probably need to talk more about that and how folks who are in professions where you have to be boom, 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 how do you deal with that? My doctor never gave me Adderall. I was asking for Adderall, help me out, But yeah, so the menopause stuff, the hot flashes, the vaginal dryness, the moodiness, to really think about how for younger women who are diagnosed with breast cancer are going to enter that at a much earlier stage than, biologically what we see for persons, living a normal life. But yeah, I think that's one piece, the menopause. Because if I had known, if I had been able to name it, I think I probably would have flourished better in my 30s before Oprah started putting stuff on TV. So yeah, that's one.
Yeah. Certainly that is an important issue. Oftentimes the medications we use will put women into menopause, and for men it may reduce their testosterone levels as well. You mentioned you've got 3 kids. They're now
college age.
But at the time, you mentioned life changes. They were younger. And we note that, again, a uniqueness of being kind of in your middle ages is you're potentially a sandwich generation person, right? You have parents and your kids. Can you talk a little bit more about what went well, what could have gone better as it relates to, you've got all these responsibilities, you're I imagine, protective of your kids and what they're going through at the time, and yet you've got something real going on in your life. And so there's this maybe tension between being honest with them, vulnerable with them, and yet at the same time trying to protect them like any good parent, I think, tries to do in some ways.
Yeah, so my superwoman complex, it prevented me from asking for help. So if you know of a loved one or a friend who's going through a healthcare journey, cancer or something else, don't ask them what they need, just show up and give them something. And part of my guilt that I have is mom guilt. So my son, at the time of my diagnosis, I believe was like 8 or so. And part of the recovery from the double mastectomy is you have the what do they call them? These things?
The binders.
The binders and the drains.
Oh, and the drains, yeah.
The things that they blow up with the air. What is that called? Expanders. Thank you. Okay, yes. And so imagine, body issue complex, again, I was a clinician on this side, but it was so hard for me to be a patient, so hard for me to advocate for self. So I was squeamish about draining my own bulbs. So my 8-year-old son was my bulb drainer, right? And because I couldn't look, it was just too much for me. Lo and behold, now he's a sophomore at Columbia in New York, and I know my kids, we know our kids, but it took me to listen to my son talking to an adult about his career path, and me recognizing that, because in high school he did research. We live in Chicago, so he had the privilege of working with University of Chicago to do research in a cardiology lab. I never knew it was an oncocardiology lab. Now, as a sophomore at Columbia, he's working in a cancer research lab. I knew he had a job. I knew he was doing research, but not connecting the dots. So hearing him in this conversation that his aspiration is to be a Dr. Kamal, I was like darn near at tears. And when Dr. Kamal and I were speaking a few days ago and he was telling his story about his mom, it's like, this is happening. This is happening in real time. This 8-year-old who drained my bulbs saw some type of connected purpose and is now pursuing research and wanting to be a physician and a treater in this space. And so, it makes me soft, and I don't get soft about anything, guys. But, it helps me feel better about the mom guilt because there's some purpose there. And his sisters, they're doing stuff. They're doing media and other stuff. But, yeah, that's a whole nother thing. But that boy of mine. So thank you for Dr. Kamal for sharing your personal, story and connection to how you're operating as a professional, for me to recognize, like, oh my gosh, this is happening to me, but I'm on autopilot and I'm just paying tuition, but not really looking at, this is, in alignment with what he experienced as my caregiver, essentially, and now that he's in his studies, so, yeah, whew, goodness.
Yeah. Should be very proud. Ramona, we did connect around that because I was probably 20 years ago was the bulb drainer for my mom too. So I remember those moments. And my mom was a very learned person, not in healthcare, but had a PhD in physics and was not squeamish about anything because she was a really good mom. Yeah. And we were 2 brothers and a sister, and we were messy and a lot of reasons why you wouldn't want to be squeamish around us. But yeah, and it was very formative for me too, to be a caregiver. So you mentioned advocacy. And there's advocacy at policy levels and big levels, but there's also as an individual. You were going through a journey where people were kind of listening to you, but and to your point, you were below the age where we would for an average risk person recommend a mammogram for routine, right? Absence of symptoms, absence of findings, we wouldn't do it. And so I wonder about the people out there, women and men, who may feel like, something's not right. Something seems off. I think I feel something. Maybe they're not getting the type of reaction that they're expecting from their healthcare provider. How do they advocate for themselves?
Yeah, there are plenty of toolkits and best practices that we see with advocacy organizations, and I'm thankful. I love Courtney and the work that she's doing with her organization, taking her own patient journey in the breast cancer space and taking best practices and applying them to prostate. We do have some area of opportunity to reach more patients, like that person who's sitting at home in front of their TV depressed, that's maybe not showing up at our events or showing up at our webinars, that we can empower with those same resources. But I think the more that we can demystify this health conversation, the more that we can provide education, that's a tool of empowerment so that persons can own whatever piece of their journey they can and really have the information that's needed to make the best decisions about their health. I don't know if Rodney's still in the room, but when he was at J&J, he had a great program around prostate health. where Shannon Sharp was like the spokesperson. This was before Club Shay Shay, but we just knew him as an NFL player. And it was, again, targeting African American and Latino men, and it did really well with normalizing the conversation about, have you checked your prostate or have you been screened? So I think it's continuing to have vehicles like that where we're talking about health, but not necessarily under the moniker of health, because that will turn people off, right? So Courtney, had Matthew Knowles talking about his breast cancer journey. We forget men get breast cancer too. So the more that we can use this collaboration here, public-private, collaboration of, industry professionals working with advocacy groups, and not just for the sake of I need to recruit for a study, but let's think about longitudinal ways that we can give funding, that we can give resources for these advocacy groups to reach persons and use these resources that have been developed to help change the narrative for those who are out there, because we have some work to do. So to answer your question, I think the more that we normalize conversations around health, the more that we demystify conversations around health, that's when we get to really empowering patients. Because we have to respect there's a hierarchy, right? So as physicians, when you're with a patient, your physician thinks that you're God, darn near, right? So we have to recognize that and maybe go on with some deference. And that's where, working with the patient advocacy groups and using other tools to drive these conversations, they have shown impact. I did a lot of work for COVID vaccine when I was at J&J, and how to get rid of the misinformation around clinical trials and vaccines. And so best practices that we're learning in those spaces, we're really, looking to implement in other spaces. But empowering the patients, I think that's key to help them when they're in the context of either looking to be in research or even in the context of having an appointment with their provider.
Yeah, that's great. In my clinical practice, to understand how people make decisions, I oftentimes ask them, when they think about the future, what are they hopeful for? And when they think about the future, what are they worried about? And the worry question is actually a really important one, because for those of you who understand behavioral economics, humans are unique creatures. We actually make more decisions based on what we're worried about than actually what we're hopeful for. It's a just unique way, right? We make decisions by thinking about how do we reduce the amount of worry or anxiety that we might have. So the reason I ask that of patients is because it'll give me a sense of how they might make decisions. So you've been very forthright, Ramona, in a lot of ways. So if I were to ask you the question, you're in an active journey. As you think about the future, what are you most hopeful for, and what are you most worried about?
So I'm hopeful of this younger generation that's coming behind us, because I'm old now. I recognize that. I'm an auntie, right? That's what they call old people. But I think about I think about the advances in how we're delivering health information in healthcare. So the virtual model, telehealth, gamification, recognizing that you can take the foundations of Fortnite and use that to create a tool that's going to help us better understand the patient journey or patient experience or whatever, right? So I'm hopeful for that. We're seeing so many disruptive things come into this healthcare delivery space where we're inviting non-traditional players, so tech, AI, but again, as we do that, we have to realize the humanistic piece of all that. What I'm worried about is just the funding threats that we're experiencing now, because I tell you, as a pharmaceutical executive, we really rely on the basic research that are happening in a lot of these institutions that are dependent on NIH funding to make a decision whether or not we will financially support the research and bring it into our fold. So if we're jeopardizing what's happening at that basic research level, what are we going to miss out on, as we look for curative therapies or new innovative therapies in different health spaces? So that's what I'm excited about, and that's what I'm concerned about.
Yeah. So we're in DC, and I like to ask this question of folks, and I think Lisa probably taught me this question too, right? Let's imagine you're in front of House Energy and Commerce, and you get invited to give testimony to talk about not only your experience, but to your point, the criticality of policy to preserve what we've accomplished so far. In 30 years, reducing cancer mortality by 34%. But I remind everyone, because we're all here because we believe this, the thing we haven't yet bent is the suffering curve from cancer. Yeah. Because if you look at the number of people being diagnosed this year, it's 2 million. But if you look 10 years ago, it was 1.7. You look 20 years ago, it was 1.5. Right? So the number of people who have stories that are altering their life has not been a number that has shifted, despite the fact that less people are dying, which is it's a good news, bad news story. So we've made a lot of momentum, but we've got a lot more work to do. All right, so I yield to you for the next 4 minutes. Dr. Burris, your expert testimony on what you believe are the critical policy interventions to learn the biology and the being of a person going through a cancer journey who may be a little younger, such that what we get over the next 5-10 years, because that's really the investment now, is into the future, means such that maybe less people get diagnosed, but also that the experience is better. What say you that we need to do?
Yeah, so recognizing that healthcare is a basic human right. So just like we have different things that we have social justice around, we need to start elevating the healthcare piece. If we, the data supports this. If we look at incidence and prevalence of cancer, we see what Dr. Kamal mentioned. But then if you look at the morbidity and mortality and the disparities that you see there, and it's not just for one cancer, not just for two, not just for three, there are some alarming issues there. And if we think about the strength of a society, the strength of the economy is the health of its people. We have to keep that top of mind, and that's why policy is so important. I think, it's not just about the healthcare delivery, it's not just about the pharma companies, the insurance companies, it's really about social determinants of health. We're recognizing as we see cancers in younger people, as we see more aggressive cancers, it's not just about what a person eats. It's not even really just about the genomics. There are so many other threats to how healthcare is changing for us in real time. And I think that's where policy is important, to recognize that social determinants of health. So a person's zip code can determine their health. Education is key. We need a pipeline of more Dr. Kamals. We need folks who are in research, but if we're not supporting the underpinnings of what good education is, how do we expect to get it? Housing, that's an issue. As an HIV clinician, when I was a pharmacist trying to talk to someone about medication adherence, I really couldn't talk to that person unless I addressed whether they had a housing issue or substance abuse or whatever was spilling over into how they were showing up as a patient. So housing, transportation, again, these are things that are critical drivers for health, but recognizing that health of our country, of our society, is critical to the vitality of our society and of our country. So that will be like my spiel. That wasn't 4 minutes, but
It's good.
Okay.
It's really good. Okay. All right. I'm gonna yield back 30 seconds to you, Dr. Burris, as well, because I think it's a nice to put a fine point on it. At ACS, we with my team, we sort of had this audacity of conviction. We printed a T-shirt that we give to all of our employees and patient support that just said, "We're the freaking American Cancer Society." Yeah. And the idea was, it's a great shirt, by the way. It's but it was to reflect a sense of like, that's who we are. Like, we have to solve this problem. This is not someone else's problem to solve. We have to do this. And I don't mean by ourselves, but in partnership with others. So you've had many moments that I think are hashtagable moments, or what I would call a T-shirt moment. One involved the word nipple, which I thought was interesting.
Yes.
So if we were to leave with a hashtag or a T-shirt to emphasize what you've been talking about, what would it be?
I think I'm going to go back to the worthiness piece. We've been under attack. Coming out of the pandemic, we've yet to see the impact of isolation. We've yet to see the impact of folks who are losing their jobs and all that. So recognizing that you are worthy, whether it's using your voice in the policy advocacy space, whether it's using your voice at work, whether you have a seat at the table or not, whether it's using your voice for your family dynamic, right, and empowering those who are in that circle. I think knowing your worth has a trickle-down, a spillover effect that we would see that will move mountains in many ways that we need to move them. But really, again, just recognizing that society has been under attack for a while, so we have to pull it together. So pull up your big girl draws and big boy draws, and let's do it.
Dr. Burris, ladies and gentlemen. Fantastic. Fantastic.
So I'm going to move us to our next panel. Yep. So I'm going to welcome up Andi Hasley from ACS Can Volunteer from West Virginia.
Thank you, Dr. Kamal, and thank you, Dr. Burris. I personally think your hashtag should be hashtag nipple boss. Right there. She's a tough act to follow, but I'm proud to do it. So for as long as I can remember, and like a lot of oldest daughters, I've been a rule follower. Growing up, that meant we never missed a dentist appointment, our annual doctor's checkup. Our vaccinations were always on schedule. And when I became an adult, my mom's voice was still in my head saying, "Don't put off what can be fixed." So when I turned 40 in November of 2019, I knew it was time for my first mammogram. But at the time, I was a music teacher and usually saved my preventative health care appointments for the summer. In May of 2020, I found out that my longtime doctor, someone who knew my history and who I trusted, was moving out of the area. And so I decided to schedule everything early before she left, including my very first mammogram. I really didn't think twice about it. I had no family history of breast cancer. I was healthy and active. But 5 days after the mammogram, I got my results on my chart. There were some abnormalities and I would need a biopsy. My family doctor really wasn't concerned. She said this happens a lot with first mammograms. Of course, we'll schedule the biopsy, but your cancer likelihood is less than 10%. But 2 weeks later, the day after my biopsy, Dr. Gusick called. "Andi, I can't believe it, but you have cancer." I was in an oncologist office 18 hours later, and I was diagnosed with stage 0 DCIS. Because the cancer was caught so early, my prognosis was good. The treatment plan was manageable, maybe less invasive than if I had waited. And in case you didn't catch the date of that diagnosis, this was all happening in the middle of COVID-19. After that very first appointment, I went to every appointment alone. It was hard, but truthfully, it was probably harder on my husband than it was on me. But this made me appreciate the support system that I have and one that so many others don't. I realized how lucky I was in other ways too. I had several options for care, all within 30 minutes of my house. I lived 7 minutes from the hospital where I received radiation. I know people who have had to drive 2 hours every day just to get treatment. And I can't imagine the added stress of time to an already life-changing diagnosis. But the truth is, I had really minimal barriers to care, and so many others don't have that privilege. Imagine if it had taken a year to schedule my very first mammogram. It happens. Or if I hadn't had health insurance, or if I hadn't been raised by someone who valued preventative care, had the education to know how important it is, and the resources to make sure that it was part of raising a family, my outcome could have looked very different. In the words of my mom, you can't fix a problem that you don't know exists. And I was really fortunate, not just to find the problem early, but to have the resources, support, and access to fix it. Every American, no matter their zip code, should be afforded the access to early detection and treatment with which I have been blessed. Thanks to all of you for the work you do. I'm here, almost 5 years later, because of you. Thanks for having me today. And now I would like to introduce the moderator for our third and final panel of the day. Kristin Olson is currently the Senior Director of U.S. Oncology Business Policy and Public Affairs at Pfizer. With over 2 decades of experience in the oncology field, she has dedicated her career to advancing the development and delivery of treatments and support for patients living with cancer. Her full bio is available in your packet. Thank you.
Thanks so much, Andi, for sharing that story. It's so important.
Our final panel today, and thank you all for staying for the final panel. I realize there's a lot going on in the city today, so I really appreciate you staying for one of the most important discussions, I think, around solutions. What should we be advocating for to get rid of barriers to screening, and how do we create payment pathways for new technologies and interventions as they arise? Similar to the prior panel, we will have the opportunity for audience questions using the microphones in the room, and the online audience can feel free to submit questions to the panel in the Q&A box. Please help me in welcoming our panelists to the stage. Molly Guthrie. Molly Guthrie is the Vice President of Policy and Advocacy at the Susan G. Komen Foundation. In this role, she is responsible for leading Susan G. Komen's public policy and advocacy efforts through Komen's Center for Public Policy. Molly oversees Komen's work to advance key legislative and regulatory objectives at the federal, state, and local levels. In this role, she focuses on policy campaigns to increase funding for medical research and screening programs, and ensuring access to affordable, high-quality breast health and cancer services. Our next panelist, Jennifer Higgins, is the Senior Vice President of Global Public Affairs at Guardant Health. Jen is responsible for leading and directing the overall public affairs function for the company, which includes global government affairs, public policy, patient advocacy, and corporate communications. Her day-to-day work demands a collaborative, enterprise-level mindset, working in tandem with legal, compliance, and regulatory teams to support commercial growth in the US, Europe, and Asia. Earlier in her career, Jen worked for the federal government and in an advisory role to hospital executives, providing her with additional perspectives on the broader healthcare landscape. Our next panelist, Jim Matthews. Jim is a principal with Health Policy Alternatives. Jim joined Health Policy Alternatives in 2024 after a 30-year career in federal health policy. Before coming to HPA, Jim was executive director of the Medicare Payment Advisory Commission, MedPAC, from 2017 to 2023, after having served for nearly a decade as the commission's deputy director. In these leadership roles, Jim provided policy advice and analysis to the Congress and the Centers for Medicare and Medicaid Services that informed the development of major pieces of Medicare legislation and regulation. Prior to MedPAC, Jim held a variety of management and analytic positions throughout his career in health policy, having served with the Office of the Assistant Secretary for Planning and Evaluation at the U.S. Department of Health and Human Services, the U.S. Government Accountability Office, the Prospective Payment Assessment Commission, the Office of Management and Budget, and CMS. Anything else, Jim?
I have a hard time holding a job.
Oh, and our final panelist, Aaron Polak. Aaron is the Vice President of Government Affairs and Alliance Development at GRAIL, a healthcare company pioneering new technologies to advance early cancer detection. Aaron joined GRAIL in December 2019. In her role, she's responsible for federal advocacy and national alliance development. Prior to joining GRAIL, she spent 13 years in the biopharmaceutical industry, including 11 years at Merck. All right, so I'm going to start first with you, Jim. The Medicare program, which covers more than 66 million Americans, has an important role to play in ensuring access to cancer screening and early detection. One criticism of the Medicare program has been its slow adoption of new and innovative technologies, particularly those having to do with screening and detection. Can you talk about how traditional Medicare covers preventative services? And then what about Medicare Advantage plans? And how does Medicare cover requirements impact coverage in commercial markets?
Sure. First and foremost, I appreciate the invitation to speak to the group today. I thought my days of being the skunk at the picnic were behind me, but
Never.
Here I am. I would also like to say and ask your forgiveness here. I will probably slip into saying we a lot when I'm talking about MedPAC, but I am not speaking on behalf of MedPAC or, for that matter, any other federal entity. So I'm going to try and convey a few perspectives based on my experience, but I am speaking purely for myself. And I like to think that most of what I tell you will be factually correct. So first and foremost, yes, Medicare covers 66 million U.S. citizens. We currently spend about $1 trillion a year on the Medicare program. And much of what Medicare does on a day-to-day basis, even though there have been seismic shifts over time, is still rooted in the original Title 18 of the Social Security Act, and particularly with respect to preventive and screening type services. Medicare still gives great deference to Section 1862A1A, which basically says Medicare will cover anything that is medically necessary to diagnose and treat an illness or injury. There are other words that follow that provision, but the gist is basically active treatment of illness or injury or diagnose in illness or injury. And so the law has generally been silent on preventive services, screening services, and the things that have been added to the traditional fee-for-service program over the years have typically been the result of specific legislation. So it took changes in law to get Medicare to cover pneumococcal vaccine in 1981, hepatitis B for high-risk patients in 1984, and then colorectal cancer screening in 2000. Those all took specific acts of Congress in order to push the agency away from its focus on diagnosis and treatment of illness or injury. And my own perspective is the agency tends to be pretty risk-averse in straying too far away from the statute. I suspect they are going to be even more so given the Loper-Bright decision of last year. And so I would not look, absent a sea change or a wholesale interpretation of the law, for a broad reorientation of the agency with respect to preventive and screening type services. That said, I want to talk a little bit about Medicare Advantage. If anyone here has led a boring enough life that they have followed my prior professional career at all, folks will know I have a lot to critique about the Medicare Advantage program. But the Medicare Advantage program has been incredibly successful for on a number of different fronts. So currently, 54% of eligible Medicare beneficiaries are enrolled in MA. And in addition to covering the traditional A and B benefit at a lower cost to the enrollee than traditional fee-for-service, Medicare Advantage plans also have tremendous flexibility to provide supplemental benefits, partly because of their statutory underpinnings and the way they are paid. They receive rebates from the Medicare program that can cover predominantly health-related supplemental benefits. Typically, these have been things like vision, dental, hearing, meals, gym memberships, that sort of thing. But I think there is a compelling case to be made, given the relative stickiness of MA enrollees, that Medicare Advantage plans could and should make greater investments in providing preventive services, screening services, early detection services that are not necessarily covered under the traditional program through supplemental benefits. And when I say MA enrollees are sticky, the MA plan has some guarantee that the investments they make in covering these services to their enrollees will accrue in later years in the form of reduced utilization of more expensive services. With that, I will pause here.
Thanks, Jim. Jen Higgins. Guardant Health developed a blood-based test for colorectal cancer screening that was recently approved by the FDA. As was mentioned in the previous panel, innovative tests are only good if people use them. Can you talk about how Guardant Health is looking at the issue of payment and patient cost for colorectal screening?
Happy to do it, Kristin, and thanks again for the opportunity. It's exciting to be on a panel with so many great colleagues and partners in this effort. I was joking earlier that there are no policy barriers to early detection, so I'm not sure why we're having this panel, being sarcastic. There are quite a few, and I think just from the standpoint of Guardant Health, we did obviously develop and seek FDA approval last year for our colorectal cancer screening test. We are unique in the sense that we're one of the first companies to really have innovated in the space of liquid biopsy. About 12 years ago, our founders really felt that there was an opportunity to democratize access to cancer care by seeking genomic information through the blood. There are a lot of really great applications for this type of technology. We started in therapy selection because we saw an opportunity there to really help understand disease progression, how to support patients getting on the right therapies and treatments as late-stage cancer patients. But the reality is there's tremendous sort of population health opportunities if you can leverage a blood test in a setting where average risk individuals could get a blood test that was accurate and be able to detect their cancer at that earliest point. I thought that what Dawn said earlier really stood out to me in the sense that if you're a company and an innovator in this space and you're developing, as Grail and other companies in the room are, what you have to recognize is that you've got to start with sort of the end in mind, right? And so as you're designing the technology, as you're thinking about the future, we started several years ago, well before going through an FDA approval process, saying, how do we get to the finish line? But if we develop a test that isn't accessible to people, meaning I can build it and no one can come because they can't afford it and they want it, that's a problem, right? And so we could have taken a different approach, but our mindset was very much built to Jim's comments around the Medicare sort of coverage pathway. And so if you think about Medicare and you look at the landscape, we looked and evaluated a couple of things. One, is there a benefit category that allows us to sort of find that pathway to getting patients an accessible blood test early to screen for cancer? Yes, in the case of 5 cancers, there are. We looked at colorectal cancer, and one of the things we found is that, frankly, as much as we've tried really hard over the past 15 or 20 years to increase screening rates for CRC, they're not where they need to be, right? There was a targeted goal of the National Colorectal Cancer Roundtable of 80%. We haven't met that bar, right? We're still hovering in the 60s. That's a problem. So what if we were to bring forward a blood test that would get us to that bar and maybe even higher? We know the accessibility is a factor. And so one of the things that we felt focused on was that if there are 50 million people who are still not getting screened for colorectal cancer, that's a problem that a blood test can help to solve, but we have to do it the right way. So we looked at the Medicare NCD, and ironically, when I joke about policy barriers, the thing that's funny, and Jim knows this well, is that government isn't usually the most progressive when it comes to coming up with solutions before there's a problem. And this is interesting, but they developed an NCD back in 2021 to reflect the fact that they knew many companies were developing these sort of blood-based technologies starting in colorectal cancer. But could we put guardrails and parameters in place that would allow, A, for the safety of Medicare beneficiaries, a reasonable and necessary blood test, but furthermore create a pathway that others could follow behind? And so we developed a blood test with that very much thinking in mind, which is, does it meet the requirements set in the NCD, which means we know Medicare beneficiaries would have access to this on day one. So had to be FDA approved. We had to go through an FDA approval process, so we knew that well before we brought forward the test. We initiated a study back in 2019, but the reality is we needed to get that FDA approval as one anchor in that Medicare coverage. The second piece was, is the test indicated for average risk individuals 45 to 84? Yes, we knew that we were developing a study that was going to produce a result that would hopefully validate that indication with the FDA. And then finally, does the test meet the performance requirements set in place? They wanted to set a bar for sensitivity, a bar for specificity, to make sure that this was a test that we felt good, again, to Dawn's point, isn't the solution, but is allowing the patient now to go get that intervention that is going to prevent that cancer. So the blood test gets them screened, they go get the colonoscopy to follow. And so we wanted to get people what I would call in warranty, in the system, in the queue, with the ability to get screened to increase that 50 million Americans screened for cancer. And so I think when we looked at all those pieces, we met that bar, but if we wouldn't have started with the mindset of like, how do we make sure that the test is accessible, we could have taken a very different path, right? We could have just brought a test forward and saw what happened, right? But we knew it was important, but we also knew many others were going to face those challenges. And then I think the other piece of this that's important to note is that as much as we were very excited about Medicare coverage and FDA approval, The reality is there are still these ongoing barriers as it relates to clinical practice, right? The reality is physicians and payers evaluate what they use based on clinical guidelines. And so those clinical guidelines play a role, which I know we'll talk about. The U.S. Preventive Services Task Force is a huge factor in our ability to expand this coverage well beyond that 65 and over population. So we've spent the better part of the past several years focusing our energy and our advocacy efforts on prioritizing the fact that guidelines matter, right? And unfortunately, guidelines don't always move at the pace of innovation. And so we've recognized that, and we know that in order to see that widespread adoption where commercial payers are going to say, we want to cover Guardant's test and we want to make sure that every patient who goes to the doctor and wants it and gets it ordered doesn't have an out-of-pocket expense, because that's driving patient behavior, it's driving physician behavior. We have an opportunity, and so we're fortunate to be in a position to work with our partners, not only to address the guideline disparity, to hopefully open up opportunities for increased adoption of our test and make sure every patient in that 50 million that wants to get screened using a blood test has the ability to do it. But on the flip side, we're also working with ACS because they have the power of developing their own guidelines that have impact with payers in key states, about 18 states across the country. So we're doing everything we can to kind of think ahead of the curve, but we're also in the same position as many other innovators, which is we're moving fast, and government and policy are not moving as fast as they could be. And so what is the accelerant that we can create to speed up that guideline process, which is the catalyst for how payers view things, how providers view things, and frankly, how patients feel comfortable ordering a test they don't have an out-of-pocket expense for.
Thanks, Jen. I lost my dad in 2020 to late-stage colorectal cancer. He shied away from colorectal screening, and that just makes me wonder if something like a blood-based test we would have had a maybe different outcome. So thanks for working on this.
Appreciate it.
Aaron, we have heard a lot from our previous panels about the need to invest in new and innovative research, particularly as it relates to screening and early detection. GRAIL is developing a multi-cancer early detection test. Can you talk about these new tests, what they are, and how they have the potential to address existing barriers?
Thanks, Kristin. And thanks for the opportunity to be here. I'd like to thank ACS CAN for this forum. It is also always a highlight of my year because not only do we have these critical forward-looking policy discussions, but there's also data brought to the table, which makes my nerdy policy government affairs self very happy. I'm also very thankful for this table and chair because as a person who's 5 foot tall, climbing up on a stool is a terrible way to start a presentation. So it's so nice to see everyone in this room. I want to take Lisa's advice and start with the patient story. And first I want to thank Russell, Kathy, Courtney, Ramona, Andi, and Kristin for sharing your personal stories here today. There are a couple patient stories at the heart of GRAIL's founding that I want to share with you today. The first is our founding CEO. His name was Jeff Huber. He had a really cushy job at Google, but he decided to leave to come launch GRAIL because he unfortunately lost his wife, Laura, at the age of 47 to late-stage colorectal cancer. Laura's favorite color was purple. It's the reason why you see purple throughout our branding as a company. And he joined the company to try to paint a new future where we don't have to face late-stage cancer diagnosis and we can stage shift cancer detection earlier when patients have a much better chance at survival and costs are lower. Our other patient story comes from the first patients at the aha moment when MSCE technology was founded for GRAIL, which was there was a non-invasive prenatal testing clinical trial underway. We're looking in maternal blood for fetal chromosomal abnormalities. And in that study, they found a handful of women, several, who had fragments of tumor DNA circulating in their bloodstream that were very abnormal looking. Wasn't the moms, it wasn't the babies, and the aha moment was those were fragments of tumor DNA, and those women unfortunately had cancer, and they were very abnormal looking. And it was that aha moment that we realized that there are fragments of tumor DNA circulating in the blood of many cancer types when cancer starts growing in the body. And that there's the opportunity through new blood-based technologies, advanced next-generation sequencing, and AI to look in the blood to find those fragments of tumor DNA, which is a common signal across many different cancer types, and then pinpoint where in the body that cancer is growing. And the whole goal is to solve this challenge that we've heard a lot about today, which is, between 60 and 70% of cancer deaths are happening in cancers that don't have early detection today. We have 5 amazing single cancer screenings that have demonstrated time and time again the ability to save lives, reduce costs, reduce the suffering related to cancer. And we have new technologies in our hands that can change that landscape of cancer care forever. So when we think about the burden of cancer, it's what drives us at GRAIL, which is, I don't need to tell this room this, but 1 in 2 men and 1 in 3 women will be diagnosed with cancer in their lifetime. It's the leading cause of death of people under the age of 85, and we do not sit idly by. We think this status quo is totally unacceptable, and we need to move with urgency to solve the cancer burden. But we do not need to compromise rigor. GRAIL is at its heart a company that is deeply dedicated to the science related to cancer early detection. We believe we can do big, hard things, and we don't have to do them slowly, and we don't have to do them incrementally because we know what's happening. And I think every one of us has encountered a personal story with cancer, and we've heard so many compelling ones here today. So GRAIL has invested in a huge population-scale clinical program that will have enrolled over 385,000 patients in our clinical program at the end. We're committed to FDA approval. We know that's critical to getting this test in the hands of those who need them, and of course to demonstrating clinical benefit that will help ensure coverage and access. So that's the story. We are deeply invested in this science. I just want to point out, we are publishing a lot of data that's really important to inform the world, including the ability to detect different cancers early. So I'll just give you an example. Stage 1 pancreatic cancer, we have a detection of 62%. It's pretty rare to find stage 1 pancreatic cancer. This is incredibly meaningful. And if we look at the 12 deadliest cancers, the ability to detect 70% of those in stage 2. So we envision a future where we don't have to focus all of our efforts on trying to fight late-stage cancer when it's the hardest to fight, the most expensive to fight, and obviously the suffering is the highest. But as Jen said, there are huge policy barriers, and Jim, thank you, Jim, for preventive care. There is no coverage authority in Medicare for preventive services. The coverage that we have today for mammography, Pap, colorectal, and cervical screening were all done through congressional legislation. Actually, colorectal screening was the only bill that was not done in a way that is modality specific. So, the mammography coverage is mammography, cervical is Pap. But Congress had the brilliant idea when they put forward the colorectal cancer statute in 1997 to ensure that not only were colonoscopies covered, but there was an opportunity for CMS to consider coverage of new colorectal cancer screenings. We heard earlier today about the importance of the certainty of a reimbursement pathway in driving innovation. I would say that certainty of a reimbursement pathway has driven incredible innovation in colorectal cancer screening. Jen will tell you, thanks to that law, Guardant's test was FDA approved on a Monday and covered on a Thursday, right? So that has been critical, and we now have so many options available for patients. If you want to know why colorectal screening innovation is flourishing, look to that 1997 law. It is the reason why creating a law in Medicare is so important to enable coverage of multi-cancer early detection screening tests. And kudos to ACS CAN for leading that fight along with many of you in the room. And I really love the freaking American Cancer Society and American Cancer Society Cancer Action Network. I'm going to use it all the time. You could make it your official tagline. I'm just saying. To create a policy solution that is for the entire field of multi-cancer early detection tests. So this bill, crafted by the American Cancer Society, Cancer Action Network, and many of you in the room, would create coverage authority for any multi-cancer test that leverages a biosample that's FDA approved and has demonstrated clinical benefit. It's not a coverage mandate, so CMS has the opportunity to evaluate the evidence and determine if coverage is appropriate. And by getting this law in place, we're going to see tremendous innovation. We already know these tests are out there. We heard from so many today about the exciting innovation coming forward. I can't even imagine when you sort of tackle this coverage and access barrier what the field is going to blossom into. But it is very, very exciting. And the great news is, again, that there's incredible momentum. So thanks again to the American Cancer Society Cancer Action Network and so many in this room. There are now 225 House sponsors on the bill, 48 Senate sponsors, and incredible momentum to get this done this year. And I would say, you know, it is this room of people who have demonstrated and will continue to demonstrate that we can do big and hard things and we can do them quickly. So sorry, Kristin, I might have gone too far.
No,
there.
thanks, Erin. No, and personal story number 2, Erin knows this. I took that test earlier this year and paid out of pocket for it. But I would love to see everyone have access to something like that and the peace of mind that it brought to me. After working in oncology for many years, it was it did bring peace of mind to me, along with all of my other screenings that I do. So thank you for that.
Thank you.
Okay, Molly, you're next. Before we even get into a discussion on payment for new technology, let's talk about payment for existing recommended screening tests. Mammography. Mammography has been around for decades and responsible for saving the lives of many people. Can you talk about some of the cost barriers women still face to this day in getting access to breast cancer screening and what we can do about it?
Yes, thank you, Kristin, and thank you for the opportunity to speak today. There's been amazing dialogue already, and thank you to the patients for centering us on why we're here and why we do this work. As you've heard, we're lucky in the breast cancer space to have screening modalities that are covered, but we still have a pretty significant rate of late-stage diagnoses. We're still losing more than 42,000 women and men every year to this disease. So it's far from being solved in a solution, and so it's worrisome a bit that we still struggle so much on the mammography and access to breast imaging side as these new modalities are on the horizon. So in the breast cancer space, as Kristin mentioned, we are fortunate that screening mammography is covered at no cost to the patient right now as a result of the Affordable Care Act and the tie to the United States Preventative Services Task Force, which has moved our screening rates higher and moved things forward for individuals at average risk. It's kind of where the good news stops. And then we have a twofold issue. One, for women that are at average risk and they go and get their screening mammogram done, if there's something suspicious on that mammogram, they then require diagnostic follow-up before the decision is made on a biopsy or not. And so that diagnostic testing comes with out-of-pocket cost. I historically have referred to it as we just kick the can a little bit further down the road, unfortunately, but I love how it was phrased earlier as a teaser. So we're getting people in the door, we're getting them to get their screening done, but then they find out there's something suspicious and hey, if you want to find out more, you're going to have to pay out of pocket in order to get that testing done. On the other side of the issue front are those women that are at higher risk for breast cancer. Again, we are fortunate that it's not just screening mammography. We have other breast imaging modalities for the early detection of breast cancer. And with the investment in research and early detection and risk factors in breast cancer, we now know that screening mammography at age 40 every year is not necessarily the right path for every single woman. So if you are deemed to be at higher risk of breast cancer, guidelines recommend that you might be receiving an ultrasound or an MRI rather than that traditional mammography. Additionally, those people that unfortunately don't utilize the screening mammography early enough when they present at their providers with their cancer it then falls into the supplemental imaging or diagnostic imaging category. So coverage does not equate to access. And so what we've found is this affordability issue, and that the out-of-pocket costs, which can range on the very low end to $25 or $50 for the patient, to the high end of upwards of $3,000 per exam, is preventing people from getting to an earlier diagnosis. And this is true. I know earlier today there was mention that white women and Black women have pretty similar utilization of screening mammography, but yet Black women see a devastating disparity when it is late-stage diagnoses and mortality. And so there's a breakdown happening between that initial screening and getting to a diagnosis. And a lot of our conversations and data collection has shown it happens in that follow-up diagnostic category where there is that out-of-pocket requirement. And so we've been working to address this. We started our efforts at the Center for Public Policy at Susan G. Komen in 2017 at the state level. And I'm happy to share that as of today, and hopefully it will go up in the very near future, but as of today, there are 29 states that have passed policy that outright eliminate patient cost sharing for medically necessary diagnostic or supplemental imaging. We continue to move forward the conversation federally. We have a federal bill called the Access to Breast Cancer Diagnosis Act that would do the same for federally regulated plans to eliminate that cost sharing. One other tidbit that I will add, just hearing the conversation from earlier panels, why aren't we doing these for all cancers? And I do not disagree. And interestingly, one of the arguments and pushbacks that we get from state legislatures is, well, if we do this for breast cancer, we have to do it for all cancers. And my response is, so what? And we have a wonderful foundation now in those 29 states that there is that coverage, no cost coverage for breast imaging, that I implore other groups to utilize so that we can get that no cost coverage for other disease states as well.
Thanks, Molly. All right, we're going to try something a little bit different. I'm going to ask Molly, Jen, and Aaron to answer the question, how should we make the economic case to policymakers for creating payment pathways and removing patient costs for recommended preventive services? Then Jim, given your extensive background in government service, I'm going to ask you to opine on which of those arguments do you think a member of Congress or member of an administration might find to be most persuasive. So there will be a winner.
You didn't tell us that, Kristin.
Who wants to go first?
I'm happy to go first because I feel like I'm in a unique area compared to you two, in that we do have a payment pathway for these modalities for breast cancer. They're all covered by Medicare, but come with the 20% required cost sharing for people in those plans. And so the case that we do make for lawmakers, although we don't have federal legislation yet to address this issue in Medicare, is the cost-benefit analysis. So as you mentioned specifically for Medicare Advantage, but Medicare probably across the board, you're going to have those individuals in your plans for longer than the traditional employer-sponsored one-year time period. And so if you make the investment to make these imaging services available to women and men at no cost following guidelines, in the long run, you're actually going to be saving money, because we know breast cancer is 5 times more expensive to treat once it has advanced beyond early stage. And so really looking again at that cost benefit analysis, we know that it's going to be saving money in the long road, and that we're following medically approved guidelines with regards to those the coverage of those exams.
Great. Thanks, Molly. Jen, would you like to go next?
I feel like this is like fun. It's like a debate prep. I would just say a couple of things. One, if you think about the amount of money that we spend on healthcare in this country, and then you think about the amount of money that's spent on cancer care, the vast majority of that $250 billion annually that's spent on cancer care is spent on interventions, right? It's spent on treatment, which is important and critical. But the reality is our current reimbursement system, our current paradigm for how we pay for things, doesn't reflect the value of diagnostics, doesn't reflect the value of test and screening and early detection in a fundamental way. We think about care and cancer on the back end, not on the front end, right? And so if we were able to treat and incentivize prevention and early detection in the way that we invest in treatment, cures, and solutions, we could find a way to balance that scale a little bit. And I think to some extent, we talk about imaging too, we think about it from a diagnostic journey. We do invest a great deal in imaging, but if I look at the sort of value that's brought for companies that are developing early detection tests, blood tests that can be done in a primary care office or in a mobile phlebotomy lab in a parking lot, the cost differential on that is significant. And then we also know that prevention saves lives, right? So if we look fundamentally at the ability to detect early cancer at its earliest point, there's tremendous economic value in spending that money in that way. But frankly, our system currently has what I would call a misalignment of incentives that skews much more towards treatment and management of care rather than prevention and early detection.
Thanks, Jen. Erin?
Totally agree, Jen. The president of our company often says we need to move it from a break-it-and-fix-it healthcare system to one that tries to get ahead of disease and prevent it and detect it early. And I think there's incredible value there. We've talked a lot about the burden in general of cancer. I'll specifically focus on Medicare to make the case for coverage and access of innovative multi-cancer technologies. 7 out of 10 cancer deaths are occurring in Medicare beneficiaries, and the median age of cancer diagnosis is 66, which is incredibly young, and still like a lot of value in detecting cancer early. And the incidence of cancer in the Medicare population, as I said, because that burden is so high with 7 out of 10 cancer deaths, the cost burden is very significant in Medicare. So if we look at the next 10 years of Medicare spending on cancer care, Medicare is going to spend $1 trillion on cancer care. And as Jen said, the vast majority of that, 75 cents of every dollar, will be focused on late stage cancer when outcomes are the worst and costs are the highest. So we can make a very small investment in bringing new early detection technologies to patients to deliver 4 times better outcomes at half the cost. Early detection is a hugely powerful tool in the cancer toolbox. And if we look, we know the value of, Lisa said it earlier, today's cancer screenings have averted 4.5 million deaths. We know the value of cancer screening. We look at the University of Michigan's recent study that said that current cancer screenings have added at least $6.5 trillion in added economic benefit. And of course, we have the ability to look at new tools to complement existing cancer screening. So MSCED tests will be used in complement to today's standard of care cancer screenings. And by doing that, we're actually going to make the entire cancer screening paradigm work better for patients and the healthcare system. So multi-cancer early detection tests are moving from looking for individual cancers to looking at an individual for any type of cancer that can be found that is shedding into the bloodstream, right? So the idea is these tests are designed to maximize early cancer detection and do it in a way that's feasible on a population scale. So you also have to make sure that you're looking at harms. So these tests are really tuned to have a very low false positive rate. So when you add them and complement today's existing cancer screenings, you actually detect way more cancers earlier by adding only a small additional false positive rate, addition on false positives, making the whole signal to noise ratio of the entire cancer system work better. So when we look at trying to address the 60 to 70% of the cancer burden, including rare cancers and others, we're not going to be able to get there by adding another 10 single cancer screenings on top of our current paradigm. The cumulative costs, the cumulative false positive rates, the patient burden will be too high. There's absolutely an important role for single cancer screenings, but when we're trying to get to maximum early cancer detection at population scale, this is where there's a lot of value for Medicare to consider multi-cancer early detection testing.
Thank you. All right. What's your verdict?
Right. At the risk of becoming even more unpopular with this audience.
It's okay, Jim. We appreciate you.
Got to be me. So again, I am not speaking on behalf of my prior employer or any government agency whatsoever. A couple of the panelists have touched on something that guided my thinking on this kind of thing when I was at MedPAC, but not flat out directly. But I'm going to detour a little bit and say when I was at MedPAC, and I think this is still this, the same set of guiding principles, there were three things that we would look at with respect to any payment policy that we happened to be looking at. Preventive services, physician payment, post-acute care, Part D, prescription drugs. One was, is Medicare paying appropriately to ensure beneficiary access to high-quality care? The second was, are we paying providers equitably? Are we paying this provider a comparable amount for doing this as we are this provider? And then third, and this is the one I'm going to focus on, and I'm going to make everyone mad here for a minute, are we creating policy in the best interest of the taxpayers and beneficiaries who fund the Medicare program? And I will admit to having a fairly myopic focus on that last principle when I was at MedPAC, and it was rooted in the fact that Medicare is a publicly funded program. Every dollar of this program is paid for by taxpayers, beneficiaries, and the way I got through the working week, in addition to a lot of good sour mash Kentucky whiskey at the end of the week, was focusing on a fairly narrow set of questions. What does this cost, and what is the program and its beneficiaries getting out of whatever is being put in front of me? And again, it ranged the gamut: durable medical equipment, you name it. And that was driven by the demographics that are underlying the Medicare program. So when Medicare was first established in 1965, there were about 4.5 workers funding each beneficiary in the Medicare program. Right now, that number is 2.4, if I recall correctly, and as the baby boomers age into the program, that ratio will decline even further. And so from my perspective, again, very narrow, very cold-hearted government bean counter, it was incumbent to focus on the value that Medicare was getting out of anything that was being put in front of us at MedPAC or policymakers in general, because we advise the Congress, the committees with jurisdiction over Medicare, what should we do on this issue? I've got a stakeholder who's put this in front of us. How should I think about it? That's always was my true north. And so with respect to preventive services, and again, I'm not disparaging in any way, shape, or form the human benefits that everyone on this panel and the earlier panels had mentioned in terms of quality of life, in terms of productive life, that kind of thing, but just focusing on the economics. What is the Medicare program getting out of a given investment? And on any given day, people would come in and say, I got this new thing, it costs, $1 billion, but it's going to be great, don't worry about it. And then it turns out it was, Aduhelm, which really moved the needle on, Part B expenditures and the premiums that beneficiaries pay. And then after the fact, a lot of stuff came out about the approval process, about some of the clinical trial results, that kind of thing. And I had got my head handed to me for the position MedPAC took on Aduhelm, and I do not regret it. But going back to what you are interested in here, and I'll stop talking in a minute, to the extent that there is value in early detection, prevention, screening, that sort of thing, the thing that is most compelling to me and the people like me who sit in positions in the government making these kind of decisions is, what is it going to do with respect to the finances of these public programs that are being paid for by everyone in this room, everyone in this country in one way, shape, or form? And so if there is a financial benefit to early detection It forgoes more expensive institutional care later in the disease progression, and you can bring data to that. That is always the most compelling arguments. And again, it's not to diminish the other, human side of, the equation that I know nothing about, just to be completely candid. But just given the state of the economy, state of finances, that's kind of what drove a lot of MedPAC's decision-making.
Can I just add something there really quickly?
Sure.
Which is, I think that's a great point, and I think what's interesting about sort of our healthcare system vis-a-vis, let's say, the NHS, which I know Grail and both Garden have done work with, is that you're seeing these single-payer systems who are recognizing that they do have to make these investments now, and all they care about is not spending money, right? So they have that mindset of, like, I don't want to spend money in the late state on sick care, so I'm actually open to using a multi-cancer test or testing out an option to make sure I'm getting a patient on the right therapy, on the right treatment sooner, so that we can avoid sort of cost downstream, right? So I think it's interesting that, like, we can't get our system in there, but we have these single-payer models that, again, are still very conservative about how they spend, but recognize that there's opportunities in the utilization of these technologies despite cost.
That's a really good example. I'm a Gen X mom, so you all get a trophy for your answer. I'm gonna open it up and see if there are any questions. Pam, do we have any in from online, or do we have anybody in the room who'd like to ask our panelists a question?
I would like to say if we need to convince anyone on anything, we should just send Kathy Ottele in and the ACS Can Blue Shirt Army, because it's
Absolutely.
I have one addendum. So we've talked, I spoke about privately insured. We've talked about Medicare, but I do think there are pressing issues, obviously, in the Medicaid population, but also the uninsured. And so many of us in disease cancer advocacy have been fortunate to have phenomenal programs out of the CDC that provide preventative screening, diagnosis, and navigation into treatment when it comes to breast cancer. And those have been long supported. For the breast and cervical program, it's been around for 30 plus years. And for the first time, we're seeing a threat to that from the administration. It's yet to be seen if Congress will follow up on that. But I do think that's vitally important in this discussion, because in breast cancer, for example, the screening program has diagnosed 80,000 women with breast cancer. And so if we get rid of that entity while also potentially making changes to Medicaid, the impact is going to be devastating across the country. So I just want to make sure we're looking at all areas of the access and insurance aspects, because there are a multitude of proactive policies on the plate, but there's also some really important defensive work that has to happen.
A really great point, Molly. Anybody else want to bring up any last point? Oh, we have some questions.
Sorry. Thank you. So the question about payment for follow-up care is really existential in some ways. But yet, to your point, Jim, it's a very thorny question to answer. And Susan, you made a point about if it's breast cancer, what about the other cancers? And one thing I will offer is that I think we should probably describe them as follow-up care as part of the screening continuum. I think that's part of the argument that's made successfully for colorectal cancer. In some ways, colonoscopy is part of the screening toolbox, and so that probably made it a little bit easier. And I guess the question I have for the panel and for all of us is, maybe Jim is your question, or Molly, I'm not sure who. So if let's assume is the biopsy or the follow-up ultrasound or test that's needed, if you cover that as diagnostic tests, to your point, would you cover other diagnostic tests that Medicare beneficiaries receive? Or would you just limit it to, if we get that question back, how do we answer it, that this is screening is special versus, I'm trying to diagnose someone with anemia, right, who has symptoms. How do you make that differentiation of the case for why cancer screening is special, should be covered for follow-up versus other diagnostic testing?
That's a great question. Anybody want to take that?
I would just say from our advocacy work, we do frame it in that sense, right? It's part of the continuum. And if we really want to realize the benefit of early detection and better outcomes for the patient, lower cost for the healthcare system, we have to look at it holistically rather than the one-off way that the system is set up now. Because even in breast cancer, right, we're dealing with the screening mechanisms, but biopsy still needs to be addressed too. There's still a patient cost for that, and that's all before someone even gets to a potential diagnosis and the financial ruin that falls on the shoulders of too many patients. But
Jim, putting on your hat for a second, on the value proposition, if we've determined that cancer screening is valuable and patients should have zero cost sharing, when you get to a positive screening test and a patient then goes to diagnostic follow-up, the likelihood of that patient having cancer is much higher than it was when they were entering through the screening door, right? And so there's that diagnostic follow-up should be considered a very high value, and we should be thinking about, to your point, Dr. Dubeni, ways to ensure that the entire continuum is working to drive early detection and ultimately treatment, which is required to get better outcomes for patients and bend the cancer burden.
Thanks. Question on that side of the room?
Hi. A theme I heard on the second panel was it was about infrastructure, and that's how we get access, affordable, equitable access to cancer screening and early detection. And I appreciate this discussion around payment pathways. And Molly, you just brought up the CDC programs as another way to do that. Can you think about other levers, particularly policy levers, that address payment and cost that aren't just creating new pathways in Medicare, whether it's the CDC programs or in the first panel, we talked about HEDIS measures. What are those other considerations that impact cost of the definition of follow-up testing? What are those other considerations we need to take as we're doing these policy levers that address cost and payment pathways?
Jim, do you have any thoughts on that?
Yeah, I can maybe take a stab at this, but arguably a lot of the payment mechanisms within the Medicare program are kind of statutorily constrained in very limiting ways. So under the Medicare physician fee schedule, there's a whole process through which individual services are given relative value units that are multiplied by a conversion factor that's multiplied by a geographic adjustment factor that in the end spits out a payment. But it's a fairly Byzantine process. And each of the payment systems, inpatient hospital, outpatient hospital, has similar statutory constructs. And so if something truly revolutionary comes along, Medicare is likely going to pay for it in the context of one of those existing constructs that may or may not value it relative to the impact it has on the patient's health or subsequent downstream spending. Medicare is likely to value that thing from the perspective of its input costs relative to other services. But if this does happen to deliver a 10 or 20 or 30-fold return on investment in terms of avoiding downstream costs, Medicare isn't going to do that. Medicare has tried over the last going on 20 years now to experiment with various value-based purchasing programs through CMMI or through the individual payment systems where the program tries to put incentives in place for high quality, high value care and reward providers accordingly. My own personal opinion is those things have fallen well short of where they need to be in terms of rewarding truly innovative care and rewarding providers for obtaining the best possible outcomes for their patients. And at the end of the day, I think this is a political problem. There is not the will to put the kind of teeth behind those kind of programs that would be necessary to truly, reward good process and penalize bad processes.
Great. Any other questions? Okay. So I want to thank our panelists. Thank you so much for coming and sharing this knowledge with us. I'd also like to thank Lisa and Pam for inviting me to be a moderator. It really, truly is an honor. I know we've been doing this for many, many years, and I've never been up here before, so I really appreciate you thinking of me. And I'm going to hand it over to Lisa.
Wow. So it's always a good sign of a great day when the room is still full towards the end of the day, right? So first of all, so many people to say thank you to. So first, just broadly, our panelists, our moderators, our speakers, but I do want to call out our patient voices. And everyone's got a patient story in some way, but for people who are willing to stand up in front of a mic and tell their story and be willing to really use their voice, whether it's really hard, which we know can be very hard because it can bring up a lot, is what creates power as it relates to ACS CAN. So to Russell, Kathy, Andi, Ramona, and Kristin for sharing your story of your dad. I just want a huge round of applause again. And if our advocacy keeps working, we're going to continue to infiltrate every healthcare conference, conversation with patient voice in ways that we know we need to be doing more of. So much learning through all three panels, our lunchtime discussion. I think the takeaway is that there is a lot of work for us to do, and the way we're going to get to the vision that we want, which is really changing the status quo of current screening and early cancer detection, is together. We really need all the lenses that are in this room because the challenge is great as it relates to public policy intervention. And I think that we all know that in some way, shape, or manner, that pathway is the most important. So with that, I have the pleasure to note that we have already locked in 2026. So get out your calendars. May 13th, we will be back in this beautiful room. And so May 13th, 2026. Can you believe that that's a thing? Like, it's so close. And really just a huge thank you. So many takeaways. We are recorded. I believe that the entire event will be housed on fightcancer.org. I encourage you to take pieces, send it to your colleagues, tell them to listen to these compelling discussions, and much more work to come, but thank you so very much. A huge thank you again to us, our sponsors. We wouldn't be here without you. So thanks, everyone. Have a great rest of your day.